IE facts in hematology. This is first stage, step 2, CK. Coagulation disorders, normal hemostasis. Normal hemostasis is a regulated, dynamic process between thrombin-stimulated fibrin clot formation and plasmin-induced clot lysis. It is divided into 3 phases: vascular phase, spasm, platelet plug phase, plug, and coagulation phase. The vascular phase is a brief contraction of blood vessels at the site of vessel injury. The platelet phase is first activated at the site of vascular injury to form a platelet plug. It can be further subdivided into the adhesion of platelets to the disrupted endothelium, which is mediated by the binding of the platelet surface receptor GP1B to 1 Willebrand factor. Let me bring the step 1 image for that. Okay. That's weird. Not sure why it's doing mayhem. Okay. It's that thing right there. GP1B. 1 Willebrand factor should be right there. Okay. I don't like this image. I like the 2021 version of this image. Forget that. Okay, so the adhesion of platelets to the disrupted endothelium, which is mediated by the binding of the platelet surface receptor GP1B to 1 Willebrand factor. The aggregation of platelets at the site of bleeding mediated by the binding of the GP2B3A receptor on the platelet surface. Platelet function monitored by bleeding time. So that is important, I'm guessing. Okay, the coagulation phase. The coagulation phase can be further subdivided based on commonly obtained laboratory tests into the extrinsic pathway, fear factors, factor 7, and tissue factor monitored by prothrombin time. Okay. Yeah, that one's important too. The intrinsic pathway, more factors, factor 8, 9, 10, 11, and 12, monitored by PTT or partial thromboplastin time. Both of these pathways coverage into the common pathway, factors 1, 2, 10, 13. Key fact here is that tissue plasminogen activators are contraindicated in active, so that's TPA ones, the plases. These ones are alteplase, reteplase, streptokinase, and tenecteplase. Okay. So active bleeding or risk of bleeding, we don't use them because it breaks away the clots and it will just further cause bleeding. A known intracranial lesions, recent less than 2 months trauma or surgery to the spine or brain, history of hemorrhagic stroke, or evidence of non-hemorrhagic stroke in the past 3 months. Okay, so we don't give TPAs for that. Okay. In the setting of bleeding dysfunction, bleeding time PT and or PTT may be prolonged, depending on the cause of bleeding. Vascular injury leads to the release of one Willebrand factor and tissue factor from subendothelial vessel walls. Okay. One Willebrand factor facilitates adhesion and aggregation of platelets, forming a platelet plug. Tissue factor triggers the coagulation cascade via the extrinsic pathway with factor 7. Ultimately, the platelet plug and coagulation cascade create a fibrin mesh as shown in figure 2.7-1. This one. Okay, so common findings seen in platelet versus coagulation disorders can be found in that. Drugs affecting the cascade are shown in point 2 right here. We'll go over it. A heparin to warfarin in bridge is necessary because the onset of anticoagulation with warfarin is slow. Concurrent initiation with heparin is needed until warfarin dosing is adjusted to reach at an INR or international normalized ratio in the therapeutic range 2 to 3. In addition, proteins C and S have shorter half-lives than the other vitamin K dependent factors, 2, 7, 9, and 10, leading to a transient period of paradoxical hypercoagulability before proper anticoagulation. Warfarin versus DOAC pharmacology can be found in table 2.7-3, and treatment of a supratherapeutic INR secondary to warfarin use can be found in that. Okay, just going to make sure. DOAC was a drug of anticoagulants. What was it? Direct oral anticoagulants. Okay. Key fact: enteric bacteria synthesizes vitamin K, and neonates lack these bacteria and are prone to bleeding, which is why vitamin K is given at birth. Similarly, in children and adults, prolonged use of antibiotics could affect the normal flora, and therefore antibiotics could increase dependency. Key fact: the liver is the machinery responsible for synthesizing the vitamin K-dependent coagulation factors. Liver disease can therefore increase the bleeding tendencies. The liver is the machinery responsible for synthesizing the vitamin K-dependent coagulation factor. Liver disease can therefore increase the bleeding tendencies. Yeah, okay. So, yeah, again, 12 makes 12A or activated 12A. That in turn will cause 11 to get activated 11. That in turn makes 9, and that makes activated 9A. And 9A along with 8 and 7A will make 10A from 10, right? So we have 9A, 10A coming in, and 7A coming in as well over here. So this is 8A coming in from here into this, and this is 7A coming in from here into this. Okay, and that makes 10A. So 10A is then used, 10A is used to make prothrombin or 2 to activated 2, factor 2, which is thrombin, and then thrombin can get aggregated with fibrinogen. So fibrinogen then combines with thrombin to make fibrin monomers, which can then aggregates basically and makes the fibrin clot or platelet plug, right? I'll just go there. Once again, 12, 12A makes 11, 11A makes 10A, 9A, along with 8A and 7A, it makes 10A, and then 10A makes 2A, and then 2A makes fibrinogen to fibrin monomers, which then aggregate to make the fibrin mesh or the platelet plug. All right. The intrinsic factors are these ones. Okay, I don't want that. And extrinsic pathway is 7. Right. And that's basically it. That's important here. Okay. So anticoagulant factors, factor 10A, low molecular weight heparin, it has the greatest efficacy. Heparin, direct 10A inhibitors like epixaban or rivaroxaban, fondaparinux. Okay, so all of these block 10A. It has the XA in it, so that's 10A, so that's easy to remember like that. And here we have thrombin inhibitors, which are again heparin, and it has the greatest efficacy here. For 10A, it was lower molecular weight. That works better here, and heparin works better over here. Low molecular weight heparin as well, dalteparin or enoxaparin, again, because low molecular weight has higher efficacy for 10A, so 10A over there. Direct thrombin inhibitor has TRO in it and TRA in it, so thrombin or thrombin, and then gluten. You can remember it that way, that these are the direct thrombin inhibitors. Okay, then comes so plasmin plug, fibrin plug, a platelet plug, then becomes fibrin degraded products. How does that happen? It's when plasminogen gets activated, becomes plasmin by TPA, right? So tissue plasminogen activator. Thrombolytics, so these are your places, alteplase, retiplase, tenecteplase, and then streptokinase. All of these activate TPA, and then you have tranexamic acid and aminocaproic acid. These are important, and they basically inhibit the breakdown of clots, right? And that will reduce the bleeding. These will reduce the bleeding, basically. Okay. So that was your coagulation cascade. We missed out on the kinin cascade. That is HWK is, what was it? Heavyweight, heavy molecular weight kinin. I think that's what that is. That will become bradykinin. Bradykinin then becomes, it causes increase in vasodilation, increase in permeability, and increase in pain. Okay. Features of bleeding disorders. Okay. So platelet disorders and coagulation disorders, cytobleeding, pitaki or pitachi, echymosis, hemarthrosis, muscle bleeding, and bleeding onset after surgery or trauma. So cytobleeding for platelet disorders is usually skin, mucous membrane like epistaxis, lung, or gastrointestinal tract. In coagulation disorders, you'll have deep into soft tissues like joints and muscles. So you can basically figure it out with that. Then comes Pitaki or Pitachi. In platelet, you will see it, platelet disorders, but you won't see it in coagulation disorders. Ecchymosis, small and superficial, and large and deep for that. Okay, what was this? A discoloration of the skin resulting from bleeding underneath, typically caused by bruising. Okay? And this was small little hemorrhages. A small red or purple spot caused by bleeding into the skin. Okay, so in platelet disorder, they're small and superficial. However, in coagulation disorders, they're large and deep. Hemarthrosis, muscle bleeding, you don't see it in platelet disorders, but you'll see it in coagulation disorders. And bleeding onset after surge or trauma, it's immediate. Whereas in coagulation, it's delayed and 1 to 2. So after 1 to 2 days. You drink water. Okay. So one more time, bleeding disorders, you'll see it in the skin, mucous membrane, epistaxis, gum, gastrointestinal tract. You'll see Pitachi, you'll see ecchymosis, which are small and superficial. There won't be any hematrosis or muscle bleeding, but you will see immediate bleeding onset after surge or trauma. Whereas if you're dealing with a coagulation disorder, site of bleeding is deep on soft tissue, joints, and muscles. You won't see any Pitachi. Ecchymosis will be large and deep. Hemarthrosis will be present or muscle bleeding, and there will be delayed in bleeding onset after surge of trauma up to 1 to 2 days. Okay, coagulation pharmacology. So we're going to be dealing with medication and its mechanism, and then their lab values and miscellaneous stuff. Starting with unfractioned heparin, then warfarin, then TPAs, then the 10A inhibitors, then low molecular weight heparin, direct thrombin inhibitors, and glycoprotein 2B, 3A inhibitors. Okay. Activates antithrombin, activated antithrombin. Okay, so unfractioned heparin mechanism is activates antithrombin, right? Let's see if we can do this. Nope. Let me move stuff around. Especially to we'll just have to remember it. Unfractioned heparin activates antithrombin, activated antithrombin, then inactivates factor 10A. 2A, no, we're gonna need it. Let me see what's wrong with that. Start again. Okay, now it works. Third time's the charm. Unfractioned heparin activates antithrombin. Right, we're talking about unfractioned heparin. Over here, activated antithrombin, then inactivates 10A over here. Thrombin 2A and activates this as well. And other proteases. Lab values are increases PTT, right, because it acts on the intrinsic pathway as well. So you'll get increase in PTT. I believe from step 1, it was heparin works on PTT and this one works on PT because war is fought outside and heparin works on the inside. Okay. So PTT. Okay. Miscellaneous antidote is protamine sulfate. Safe to use in pregnancy. It's used as a bridge to warfarin, causes heparin-induced thrombocytopenia. Warfarin inhibits synthesis of vitamin K-dependent coagulation factors 2, 7, 9, 10, and to a lesser extent proteins C and S by blocking vitamin K epoxide reductase. Okay, so remember how it was? It was, let's see if I can try it out. So vitamin K was down here, and then with epoxide reductase, it becomes activated vitamin K, and then vitamin K goes into this cycle, which was inactivated factor 2, 7, 9, 10, C and S, and with the help of gamma glutamyl transferase, it was here, gamma glutamyl transferase, and activated vitamin K turns into activated factor 2, 7, 9, 10, or there was a mnemonic for it was 1972, so 1 is for 10, and then factor 972 CNS, so 1972 CNS. It activates that. Okay, so vitamin K basically works on the epoxide reductase right here. So if it blocks that out, you don't get activated vitamin K. If you don't get activated vitamin K, you don't get activated factor 1972 and CNS. Okay. So again, warfarin inhibits synthesis of vitamin K dependent coagulation factors 2, 7, 9, 10, and to a lesser extent protein CNS by blocking vitamin K epoxide reductase. There is increase in prothrombin time or ratio. So PT over INR ratio, international normals ratio. Okay. So for rapid reversal, prothrombin complex concentrate or PCC is given. Otherwise, vitamin K. I believe there was also fresh frozen plasma, but maybe not anymore. Teratogenic, low molecular weight heparin can be given instead in pregnancy. Okie dokie. Tissue plasminogen activators, TPAs, aid conversion of plasminogen to plasmin, which breaks down fibrin, include alteplase, redoplase, and tenecteplase. There's increase in PT and increase in PTT when you do this. Give this. There's no change in platelet count. That's important. Okay. Toxicity, overdose treated with aminocaproic acid, tranexamic acid, and fresh frozen plasma to decrease bleeding risks. Possibility of TPA to cause angioedema. Okay. This one also causes it, right? Bradykinin one, because ACE inhibits the stuff, so there's increased bradykinin, and then increased bradykinin causes angioedema or something like that. I may have had that backwards, but okay. Factor 10A inhibitor, epixaben, rivaroxaben, 10A, 10A, 10A. Directly inhibit factor 10A, direct oral anticoagulants or DOAC. Gotta remember this because they use that a lot. Direct oral anticoagulant. PT and PTT is not monitored here. Antidote is or reversal agent to factor 10A inhibitors is Andexanet alpha. Andexanet alpha. Okay. Lower molecular weight heparin, enoxaparin, and dalteparin mainly inhibits factor 10A, right? Because that it has the greatest efficacy over there. Anti-factor 10A, although typically not monitored by PTT. Protamine used for reversal, but less effective at reversing lower molecular weight heparin than heparin. Lower rate of heparin-induced thrombocytopenia compared to UFH. Okay, I don't know what that is. Lower molecular weight heparin, better bioavailability, and 2 to 4 times longer half-life than unfractioned heparin. Okay, so compared to unfractioned heparin. Lower molecular weight heparin, better bioavailability, and 2 to 4 times longer half-life than unfractioned heparin, usually administered subcutaneously. Direct thrombin inhibitors, dabigatran. So again, it has TRA and TRO, so you know it's about thrombin or thrombin. Bivalirudin as well. So directly inhibits factor 2A, thrombin, DOAC, PT and PTT is not monitored. They're usually only monitored for these two, right? Warfarin and heparin. Okay. Antidote reversal agent to dabigatran is idarucizumab. Okay. No reversal agent currently available for other direct thrombin inhibitors. Argatroban, often used in the case of HIT for anticoagulation instead of heparin. Okay, so if you have a case of heparin-induced thrombocytopenia, you give argatroban. Okay, and then we have glycoprotein 2B and 3A inhibitors, epcizumab, epitephetid, tirofiban. Reversibly binds to glycoprotein receptor 2B and 3A on activated platelet aggregation. PT and PTT is not monitored. Epcizumab is made from monoclonal antibody fragments. Okay, so again, unfractioned heparin, antidote is protamine sulfate. Warfarin, it's PCC for immediate, and then for long term, it's vitamin K. In pregnancy, we give low molecular weight heparin. We don't give warfarin because it is teratogenic. TPAs, it can cause angioedema. It's treated with TPAs are treated with its inhibitors, which are tranexamic acid or aminocreproic acid. And you can give fresh frozen plasma as well to decrease bleeding risks. 10A, we only have one for, oh yeah, okay. So factor 10A inhibitors, the antidote or reversal agent is andexanet alpha. It has 10E in it. Low molecular weight heparin, enoxaparin or dalteparin. Protamine is used, but it's not as effective as it would be on heparin itself. They are lower risk for HIT, and they have better bioavailability than 4 times longer than, and they're 2 to 4 times longer the half-life than unfractioned heparin. And it can be used, it's used subcutaneously, whereas the other one is used by IV. Then direct thrombin is, we only have reversal agent for dabigatran, which is idarucizumab, and for epcizumab, we don't have anything. It's just monoclonal body fragments. Okay. So for heparin, you monitor PTT. For warfarin, you monitor PT because wars are fought outside. TPAs, they increase everything because obviously it prevents clotting or breaks down the clot that's already been formed. So it increases PT and PTT. Not clot, sorry, the platelet plug that's already been formed. So, however, it doesn't cause any changes in platelet count. Then none of those matter. Okay, that's it. Moving on to warfarin versus direct oral anticoagulants. So when do you use which, I guess? So we're going to talk about mechanism of action, lab monitoring, antidote, half-life, onset, offset, metabolism, and special populations. So warfarin, mechanism is that it inhibits vitamin K epoxide reductase. Lab monitoring is PT over INR ratio. We watch out for that. Therapeutic was 2 to 3. Antidote is vitamin K, fresh frozen plasma, and PCC. Half-life is long. Onset is very slow. Offset is prolonged. Metabolism is that it gets metabolized in liver or hepatic metabolism. Special population is that patients with mechanical valves, warfarin preferred. Okay, so this is the important part that you need to remember, that we give it in people with mechanical valves. So warfarin is preferred. Poor medication adherence, so avoids warfarin, and you avoid warfarin and poor medication adherence. Okay, because you need a steady warfarin dosage to get to the therapeutic INR, which is 2 to 3. And if they keep missing doses, then it's not as good, and then you have risk of running out of CS, but not coagulants, and then you get those gangrenes and necrosis of skin and all that stuff. So avoid warfarin in that, and CKD, avoid warfarin in those as well, chronic kidney disease, because I don't know. And cost is low. DOAC mechanism of action is that it inhibits factor 10A or thrombin. Lab monitoring is not required. Antidote is idracizumab for dabigatran and annexonate alpha for factor 10A inhibitors. Okay. And then we have direct thrombin. Okay, so that was 2A, right? Okay, so idracizumab for dabigatran, annexonate alpha for factor 10A. I'm going to drink water. You guys do the same. Half-life short. Onset is rapid. Offset is short. Metabolism is renal. And special population: pregnant patients and patients with cirrhosis. Okay. The cost is high for these. Okay. Treatment of supratherapeutic INR due to warfarin management. Bleeding. Discontinue warfarin if you have bleeding. Administer vitamin K, IV and PCC. Okay. Oh, vitamin K IV, and then you add PCC to it. Monitor INR closely. INR more than 10 without bleeding. Again, discontinue warfarin and then just administer oral vitamin K and monitor INR closely. When you have INR 4.5 to 10 without bleeding, hold warfarin temporarily for few doses. Can administer low dose oral vitamin K. INR less than to 4.5 without bleeding, hold the next dose of warfarin and readjust the maintenance dose of warfarin. Okay, and let's take a. Okay, so we finished with that. Here, there's a cue about an 8-year-old boy from Eastern Europe presents with severe swelling and warmth of his knee several hours after a minor bump against a lamp post. What is the most accurate diagnostic test for his presentation? The boy has X-linked hemophilia A, most common, which is most accurately diagnosed with a specific factor 8 levels. Features of blood replacement products. So we're going to talk about fresh frozen plasma, PCC, cryoprecipitate, PRBC, and platelet. What is PRBC? Okay. PRBC. Oh, okay. Packed red blood cells. TACO is transfusion-associated circulatory overload, and TRILI is transfusion-related acute lung injury, 1 Willebrand disease, and factor. And this is prothrombin complex concentrate. Okay. So we're discussing clotting factor composition, indications, complications, and ABO compatibility required and cost. So in FFP or fresh frozen plasma, clotting factor compositions that you find inside is factor 2, 5, 7 to 13, fibrinogen at the normal plasma concentration. It's indicated for inherited coagulation factor disorders, ongoing bleeding due to liver disease, vitamin K deficiency, or warfarin anticoagulation. So you can use it in all of these. Complications are transfusion related acute lung injury and transfusion associated circulatory overload. Okay, ABO compatibility is required and the cost is high, so high cost. PCC, prothrombin complex concentrate, again you'll find the same factor 2, 7, 9, 10, protein CNS. So these are like specifically the ones vitamin K activate. Indication is acute active bleeding due to vitamin K deficiency or warfarin anticoagulation. Warfarin anticoagulation refers so much faster than FFP. Complications are some complications related to volume overload, but overall less volume. Fewer complications related to volume compared to FFP. There is risk of thrombosis. You don't need ABO compatibility, and cost is low. Cryoprecipitate, clotting factors you find are high concentration of factor 8 and 1 Willebrand factor fibrinogen as well. Indication is fibrinogen disorder, 1 Willebrand disease, disseminated intravascular coagulation, liver disease, and uremic bleeding. Complications are some complications related to volume overload, but overall less volume, fewer complications related to volume compared to FFP. Okay. So ABO compatibility is required, however, and the cost is also high. PRBC, packed RBCs. There are no clotting factors in it. It is indicated for hemoglobin lower than 7 or 8 in patients with coronary artery disease, anemia and acute blood loss contributing to hemodynamic instability. Each unit hemoglobin by 1 gram deciliter is used. Okay. Complications are hemolytic reaction, transfusion-related acute lung injury, and transfusion-associated cardiac overload. Circulatory overload. Okay. Abiocompatibility is required and cost is low. In platelets, you don't find any clotting factors either. It is indicated for platelet count lower than 10,000 if it's not bleeding, and platelet count less than 20,000 if bleeding is there or planning to undergo procedure, or 50,000 prior to surgery. Each unit increased platelet count by 6,000 per microliter. Complications are allergic reaction, transfusion-related acute lung injury, and transfusion-associated circulatory overload. Abiocompatibility is not required and cost is also low. Okay. Transfusion products. Many different blood products are transfused for a variety of reasons. Common blood replacement product composition, indications, and complications are discussed in 2.75. Okay, so it's somewhere down there. We'll go through it when we get to it. Hemophilia is clotting factor deficiencies of factor 8. So hemophilia A, which is 80% of cases. And then there is factor 9, which is hemophilia B, and then factor 11, which is hemophilia C, which increases tendency to bleed. Hemophilia A and B are X-linked recessive genetic disorders, 1 in 10,000 male births. Rarely, hemophilias can be acquired if antibodies against these factors are produced as a result of autoimmune diseases, lymphoproliferative disorders, or postpartum states. History and physical examination. Hemophilia presents in a young male, think child that is beginning to walk, 1 to 2 years of age, with spontaneous bleeding in the tissues, muscle and joints hemarthrosis that, if untreated, can lead to irreversible debilitating arthropathy and joint destruction caused by hemosiderin deposition, destruction of the cartilage and synovium, the lining of the joints, and fibrosis. Joint X-ray will show calcifications. Spontaneous intracerebral, renal, retroperitoneal, and gastrointestinal hemorrhages are also seen. Mild cases may have major hemorrhage after surgery, trauma, or dental procedures, but they are otherwise asymptomatic. Key fact here is that hemophilia A and hemophilia B are X-linked recessive genetic disorders, whereas hemophilia C is most common in people with Ashkenazi Jewish heritage, and it is often autosomal recessive. How do you diagnose it? So diagnosis is when you see prolonged PTT, factor 8, 9, and 11 are all the factors of intrinsic pathway. Okay. On basic bleeding workup, PT and bleeding times are normal. Okay, so that's how you differentiate it with other stuff. The 1 Willebrand, it's usually the one with this and 1 Willebrand that is confusing. But this one happens in boys and 1 Willebrand happened in girls. That's how I remember from step 1. I don't know if it's still the same case anymore. Okay. Best initial test, mixing study. Mixing the patient's plasma with normal plasma will correct the PTT. So when you take some patient's plasma with hemophilia A, with clotting factor 8 deficiency, and mix it with where'd it go? Normal plasma, and that should correct the PTT in hemophilia patients.
because normal plasma contains all clotting factors and will replace the missing clotting factors. In case of acquired hemophilia, adding the missing factor will not correct the PTT due to the presence of antibodies directed at the missing factor. Most accurate test is specific factor assay for factors 7, 8, 9, 11, and 12. Key fact here is that cryoprecipitate consists mainly of factor 8 and fibrinogen, with smaller concentration of factor 13, 1 Willebrand factor, and fibronectin. It is a more concentrated source of factor 8 and fibrinogen than fresh frozen plasma. It's like everyone's just hating on fresh frozen plasma here, here, here. Oh man. Treatment. Cases in which bleeding is severe or the factor level is less than 1% of normal, severe call for immediate transfusion with the missing factor. If that is unavailable, cryoprecipitate can be used. Okay, so that's the treatment. Again, cases for hemophilia A, cases or B or C. Cases in which bleeding is severe or the factor level is less than 1% of normal call or severe call for immediate severe call for immediate transfusion with the missing factor. Okay, if that is unavailable, then you just do with cryoprecipitate for that time. So here we have the workup of prolonged PTT, PBT in patient with suspected factor deficiency, APTT, activated partial thromboplastin time. Okay, so prolonged APTT. So we know that there's something wrong with the intrinsic factor. So mixing test, control plus patient's plasma, does it fix it? So if it fixes it, then you measure the factor 8, 9, and 11, so we can differentiate between A, B, and C, hemophilia A, B, and C, and Willebrand factor as well, in which case you would see bleeding time increase. Normal, so if you measure these and it's normal, then further workup is needed, but if one of these are low, then you have the factor deficiency sorted. You do the mixing test, and then there's either weak correction or no APTT correction. Then you go into the time temperature dependent. So how long it takes. So you measure factor 8 and its inhibitor, I'm guessing. Okay, factor 8 is low, then you have factor 8 deficiency. Okay, and if you measure factor 8 and inhibitor, then inhibitor is detected, then inhibitor is present. Okay, got it. So you do this mixing test, and if it gets corrected, then you can probably figure out the deficiency here. But if you can't get it corrected, then it is time and temperature dependent. So then you measure factor 8 and inhibitor. If you measure factor 8 and it comes out to be low, then it's deficient. If you find inhibitor, then it's because of the inhibitor that there is prolonged APTT. If it's not corrected and it's not time dependent or temperature dependent, then you test for lupus anticoagulant, and if it's positive, then it's lupus anticoagulant. If it's negative, then again you measure factor 8 and inhibitor, and then that's the cycle for that. Okay. Here you go. I like this photo. So again, this is 1 Willebrand factor. It comes from endothelial cells, which also has thromboplastin, TPA, and PGI2, prostaglandin I2. I believe that one's the inhibitory one. Inside endothelial cells. So when the collagen is exposed due to any type of trauma, 1 Willebrand factor gets attached to the collagen when it's exposed. and the 1 Willebrand factor then attaches the GP1B on the platelet, the receptor, and when that is there, the ADP or P2Y12 receptor gets it activates the GP2B3A insertion. Okay, so that goes outside onto the surface, and then it attaches fibrinogen to it, and then the fibrinogen also attaches the other platelets same receptor onto this, and that's how you get the aggregation. Okay, that's the gist of it. Here you need to know that clopidogrel, prasugrel, ticlodipine, they inhibit ADP P2Y12 receptor. Here GP2B and 3A inhibitors are epcizumab, epifibetid, and tirofibin. All of these inhibit these, and yep, that's it. And then comes the deficiencies you need to know. So if there's no 1 Willebrand factor, then it's basically, yeah, that's what it's called, 1 Willebrand disease. If there's no GP1B, then it's Bernard-Solier syndrome. And if there is no GP2B and 3A conjugation, then it's Glasman thrombasthenia is what it's called. Aspirin itself is a irreversible inhibitor for COX, right? So arachidonic acid converts to thromboxane A2 with the help of COX, and aspirin basically COX blocks it. Inside platelet, you will find 1 Willebrand factor and fibrinogen. Okay. Did I miss anything? Okay, thrombin, thrombomodulin complex, protein C, activated protein C. Okay. If bleeding is not severe and factor level is, oh yeah, so how do you differentiate between these two, right? You do this test, it's called the Rosenstatin test. It will come here, right here, risdositatin cofactor assay. Okay, I pronounced it wrong, but I knew what it was. If bleeding is not severe and factor level is more than 5% of normal mild or 1% to 5% of normal moderate, hemophilia A may be treated with desmopressin, which releases factor VIII from the endothelial cells. Genetic counseling may be required to screen other family members. Prophylactic administration of clotting factor concentrates is the basis of modern treatment of severe hemophilia A. Okay. Again, if bleeding is not severe and factor level is more than 5% of normal or mild, or 1% to 5% of normal or moderate, hemophilia A, okay, so if it's 1 to 5%, it's normal, it is moderate. If it's more than 5% of normal, then it's mild hemophilia A. Okay. May be treated with desmopressin. So you can treat these mild and moderate levels with desmopressin, which releases factor VIII from the endothelial cells. Genetic counseling may be required to screen other family members as well. Prophylactic administration of clotting factor concentrates is the basis of modern treatment of severe hemophilia A. Drink water. Okay. 1 Willebrand disease is the most common inherited bleeding disorder, 1% of the population. It results from an autosomal dominant defect or a deficiency in 1 Willebrand factor with a potential decrease in the level of factor VIII, which is carried by 1 Willebrand factor. The three main roles of 1 Willebrand factor are to 1. Bring platelets to the exposed subendothelium, 2. aggregate platelets, and 3. Bind to factor 8. Symptoms of von Willebrand disease are caused by platelet dysfunction and deficient factor 8, but are mild than in hemophilia. The most common cause of von Willebrand disease is type 1 von Willebrand disease, mild to moderate quantitative deficiencies in von Willebrand factor. So that was the most common form, which is type 1. It's mild to moderate quantitative deficiency. Type 2 von Willebrand disease includes qualitative defects in von Willebrand factor. So it's just bad production, manufactured von Willebrand factor. And type 3 von Willebrand disease is complete quantitative loss of von Willebrand factor. So you just don't have it. Not that it's bad quality, it's just not there. So here it's just quantitative, so it's just less than you want it to be. So you can just probably add to it, right? That's what they do. I guess there. And type 2 is that it's badly made, not that it's low in numbers, it's just bad quality. And number 3 is that you don't have it, nada. HIT syndrome is a multi-system disorder characterized by the triad of aortic stenosis, GI bleeding, and acquired von Willebrand syndrome, which results from the increased circulatory shear forces and subsequent cleavage and loss of von Willebrand factor. Okay, so again, HIT syndrome is a multi-system disorder characterized by the triad of aortic stenosis, GI bleeding, and acquired von Willebrand syndrome, which results from the increased circulatory shear forces and subsequent cleavage and loss of von Willebrand factor. Key fact here is von Willebrand disease often presents with a positive family history of bleeding tendency, normal platelet count, and clinical manifestations of platelet dysfunction such as epistaxis, menorrhagia, and others. Key fact is reduced agglutination is seen on the I'm jumping ahead. We'll come back to this one. History and physical examination often presents in childhood with recurrent and prolonged mucosal bleeding. So epistaxis, gums, gingival menorrhagia, and bleeding after dental or surgical procedures. Family history often present, and worsening of symptoms with acetylsalicylic acid use. Okay, so yeah. Diagnosis. So how do we diagnose this, right? So best initial diagnostic test is residosudden cofactor assay of patient plasma diagnostic. It measures the capacity of von Willebrand factor to agglutinate platelets and defects von Willebrand factor dysfunction. Additional diagnostic test, von Willebrand factor antigen level. Okay, so von Willebrand factor antigen level. So decreased level of antigen may be present. Factor 8 levels can also be used to detect von Willebrand factor dysfunction, but this is less specific. Initial bleeding workup showing an increased bleeding time in all von Willebrand disease types. Okay, so there's increase in bleeding time in all types of von Willebrand disease. Increase in PTT, as in hemophilia, may be seen, which is caused by low factor 8 levels. Okay, so it could be there. PT and platelet count will be normal, however, so that's always there. So let's see. Reduced agglutination is seen on the residosudden cofactor assay detects von Willebrand dysfunction. It is diagnostic for von Willebrand disease and helps to distinguish from other platelet disorders such as Bernard-Solier syndrome. Okay, so didn't go into it. Let me look into this one. Was it her ISQ? Okay, so how it works is risdiplam activates one Willebrand factor. Okay. Risdiplam activates one Willebrand factor to bind to GP1B. Failure of aggregation with risdiplam assay occurs in von Willebrand disease and Bernard-Solier syndrome. Desmopressin promotes the release of this. Okay, so how do you differentiate between those? Okay, I believe it's here somewhere. Okay. Nope. Okay, I'm just trying to figure out how to do this. Like, how does this work? So they say that it promotes activation between them. Coagulation between those, right? Where'd it go? Okay. Promotes a one Willebrand and this. So desmopressin is here. Okay, so it activates the combination of these two. So if it fails, fail of activation with this assay occurs in both of these, and then you just gotta figure out what's deficient. So in one Willebrand disease, you have a normal number of platelets and normal number of platelets in Bernard-Solier as well, but in Bernard-Solier, they're large numbers, and in one Willebrand, bleeding time is increased. PTT could be increased if there is deficient factor 8. And in Bernard-Solier, platelet count is either normal or decreased, right? And bleeding time is increased in this as well. So autosomal recessive defect in adhesion, decrease in GP1B receptors, so there is decreased platelet to one Willebrand adhesion. Okay, so lab values will show decrease in platelet aggregation and big platelets. Okay. Additional diagnostic test, we did that. One Willebrand factor antigen level, decreased levels of antigen may be present. Factor 8 levels can also be used to detect one Willebrand dysfunction, but this is less specific. Initial bleeding workup showing an increased bleeding time in all one Willebrand defect disease types. Increase in PTT, as in hemophilia, may be seen, which is caused by factor 8 levels. PT and platelet count will be normal. Treatment is best initial treatment for one Willebrand disease is desmopressin for mild to moderate disease to release the endogenous one Willebrand factor from storage sites in endothelial cells. For more severe disease, for major bleeds and surgery, and for those who do not respond to desmopressin, such as type 2 one Willebrand disease, which was the one with low quality one Willebrand factors. Patients should receive replacement therapy of one Willebrand factor or factor 8 concentrates. Antifibrinolytic agents such as aminocaproic acid or tranexamic acid can be used as adjunct treatment for bleeding from mucosal sites such as the nose, oropharynx, and urogenital tract. Control menorrhagia or menorrhea, with oral contraceptive pills, and drugs to be avoided are ASA, um, NSAIDs, and platelet function inhibitors. Key fact here is that ASA increases the risk for bleeding in patients with von Willebrand disease. Okay, and key fact is von Willebrand disease type 1 and 2 are generally, so type 1 was the one with lower levels, and type 2 was just bad quality, are generally inherited in an autosomal dominant pattern. Von Willebrand disease type 3 is inherited in an autosomal recessive pattern. So this is autosomal recessive, this is autosomal dominant. Okay, and on to hypercoagulable states. Water break. Drink water. Okay. Hypercoagulable states. Thrombophilias or prothrombotic states are all inclusive terms describing conditions that increase a patient's risk for developing thrombosis, usually venous thromboembolism disease. Etiology. Etiologies can be genetic, acquired, or physiologic. See table 2.7-6. So we are seeing table 2.7-6. Causes of hypercoagulable states. Genetic, acquired, and physiologic. So in genetic, so in genetic we have antithrombin 3 deficiency, protein C deficiency, protein S deficiency, factor V Leiden, hyperhomocystinemia, or mother father, as I used to call it. So that's, what was that? Methionine, something, I think. Methylene tetrahydrofolate reductase, right? Okay. Gene mutation, dysfibrinogenemia, plasminogen deficiency, and prothrombin G2021OA mutation. Acquired. So you can get acquired hypercoagulable states. So these are your surgery, traumas, sepsis, OCP, hormone replacement therapy, malignancy, immobilization, antiphospholipid syndrome, nephrotic syndrome, inflammatory bowel disease, smoking, obesity, varicose veins, paroxysmal nocturnal hemoglobinuria, liver disease, non-alcoholic fatty liver disease, and decompensated cirrhosis. Because this one also makes vitamin K, which is required for activated clotting factor to 1972 CNS, right? Okay. And physiologic are just pregnancy and age. Pregnancy because it increases volume mass and just volume, and RBCs, and age because it does. History and physical examination for this. Hypercoagulable states or hypercoagulable states, yeah. Thrombophilias can present with recurrent thrombotic complications, deep venous thrombosis, pulmonary embolism, arterial thrombosis, myocardial infarction, and stroke. So all of these, if they have it, they have thrombophilia or hypercoagulable state. Females may have recurrent miscarriages. Okay. Diagnosis: ruling out acquired causes of thrombosis before thrombophilia, screening such as embolization, surgery, OCP, pregnancy, and hormone replacement therapy. Okay, so ruling out acquired causes of thrombosis before thrombophilia, screening such as immobilization, surgery, OCPs, pregnancy, and hormone replacement therapy. Thrombophilia screening. So it's to be considered only in patients with a history of VTE. What was VTE? Venous thromboembolism. Venous thrombus embolism, I guess. To be considered in patients with a history of VTE in the absence of risk factor and in patients with a first degree relative who had VTE at less than 50 years of age or a first degree relative with a diagnosis of thrombophilia. Hereditary abnormality confirmed with 2 abnormal values obtained while the patient is asymptomatic and untreated, with similar values obtained in 2 other family members. Again, hereditary or abnormality confirmed with 2 abnormal values obtained while the patient is asymptomatic and untreated, with similar values obtained in 2 other family members as well. Okay. So even though they're asymptomatic, if you get abnormal values twice, as long as they're not treated and they're asymptomatic, you can diagnose it as thrombophilia. With similar values obtained in 2 other family members. Okay. Lab test: complete blood count, PT, thrombin time, PTT, fibrinogen, and assays for antithrombin and protein CNS deficiency. Treatment here is patients with a hypercoagulable state with a provoked DVT, deep venous thrombosis, or pulmonary embolism can be treated with heparin, low molecular weight heparin, warfarin, or a direct oral anticoagulant for 3 to 6 months for the first VTE event, and lifelong anticoagulation for subsequent events. So for the first one, 3 to 6 months, and if it happens again, then you gotta do it for life. If anticoagulation is contraindicated, for example, recent trauma, hemorrhage, severe uncontrolled hypertension, or if patients have recurrent DVTs on therapeutic doses of anticoagulation, an inferior vena cava filter is the next best step. Okay. Activated protein C APC resistance factor 5 Leiden. Okay. Activated protein C resistance or factor 5 Leiden. Right, this is the mutation one. Okay. Did we have any key facts that I missed? Nope. Okay. So protein CNS deficiency, hypercoagulable state with skin or tissue necrosis following warfarin administration. The most common cause of inherited thrombophilia is this factor 5 Leiden. A single point mutation in factor 5, rendering it resistant to being inactivated, broken down by activated protein C. Okay. So again, a single point mutation in factor 5, rendering it resistant to being inactivated or broken down by activated protein C. Risk for DVT or pulmonary embolism is increased 5-fold in heterozygous and 50-fold if homozygous. History and physical examination. Factor 5 Leiden. Young white patient less than 45 years of age with a personal and family history of thrombosis. For example, multiple VTEs, unusual location, and atypically young age. Gotta look up VTE. Am I saying it right? Okay, venous thromboembolism. Okay. Atypically young age. Okay. Diagnosis: disease specific tests, factor Filane, APC resistant test, functional assay or genetic testing. Disease specific test. So factor Filane, APC resistant test, as functional assay or genetic testing. Key fact here is that the liver is responsible for the synthesis of factor C and S. In cases of decompensated cirrhosis, deficiency in protein C and S can cause a hypercoagulable state. Treatment here is factor V lane mutation. For that is direct oral anticoagulation without the need of monitoring INR. Can use warfarin for 6 months with a target INR of 2 to 3 in patients who trigger concerns about compliance with medication. In individuals taking medications that can interact with direct oral anticoagulants or DOACs, or in individuals who have extreme body weight due to erratic absorption, OCPs should be avoided in patients with factor V lean. Okay, so it's contraindicated there. Heparin-induced thrombocytopenia. Water break. Okay. A drop in platelet count, more commonly observed due to unfractioned heparin than the lower molecular weight heparin. It can happen with heparin or enoxaparin. HIT type 1, a mild non-immune mediated transient decrease in platelet count that occurs 1 to 4 days after heparin initiation. The platelet nadir is typically 100K per this microliters. This type of HIT is being benign and requires only observation. No heparin interruption is required. So you keep giving it. You see something happening, but you don't worry about it. However, there is HIT type 2. It is an immunologic reaction due to the formation of platelet activating antibodies against heparin prostaglandin PG4 antigen, which leads to the formation of blood clots and a drop in platelet count. It is usually a severe and rapid, more than 50% drop in platelet count that occurs 5 to 10 days after starting heparin. HIT type 2 often presents as skin necrosis at the injection site of subcutaneous heparin. HIT rarely causes bleeding. Venous and arterial thrombosis can occur. However, VTEs are more common. Heparin discontinuation is required, and a non-heparin anticoagulant must be initiated. Key fact here is that pulmonary embolism should be suspected in a patient with rapid onset of dyspnea, pleuritic chest pain, hypoxia, tachycardia, and an increase in alveolar arterial oxygen gradient without another obvious explanation. Mnemonic, antiphospholipid syndrome, clots, coagulation defect, livedo reticularis, obstetric, recurrent miscarriage, thrombocytopenia, decrease in platelets, SLE association. Okay, again, antiphospholipid syndrome effects. So these are your clots. Coagulation defect, livedo reticularis, obstetric, recurrent miscarriages, and thrombocytopenia, so decrease in platelets and SLE association. Okay. Diagnosis. The 4 T's: score, help, differentiate thrombocytopenia due to HIT from other causes. This score includes the platelet count fall, thrombocytopenia, the timing of platelet count fall, evidence of thrombosis or skin necrosis, and the probability of other causes for the thrombocytopenia. Okay, so 4 T-scores help differentiate thrombocytopenia due to HIT from other causes. So what do we look out for? So this score includes the platelet count fall. So you look at that first. So thrombocytopenia. Then you look at the timing of the platelet count fall, right? So it's usually 4 days after you start heparin. And then evidence of thrombosis or skin necrosis. So you see something happening because of this. And then the probability of other causes for the thrombocytopenia. So is there any other thing, like you're giving OCPs, or are they smoking and stuff like that? I don't know. But that. Disease specific test. Best initial test is evidence of HIT platelet factor 4 antibodies. Okay. And most accurate test is functional assay with serotonin release assay. Okay. Treatment here is discontinuing heparin immediately upon suspicion of diagnosis and starting a direct thrombin inhibitor. So these are your fondaparinux, argatroban, and Willebrand. Okay. Warfarin should be commenced after a direct thrombin inhibitor is started and once platelet count is more than 150,000. Starting non-heparin anticoagulation is crucial to prevent arterial and venous clots. Okay. Antiphospholipid syndrome. Okay, so before that, let's do this question. A 65-year-old male was recently admitted to the hospital for management of DVT and with heparin. 2 days after his admission, he was found to have Pitachi. Lab testing identified a drop in platelet count from 180,000 to 50,000. Okay. What is the best next step in management of his thrombocytopenia? So again, heparin was started, and then 2 days after admission, he was found to have Pitachi, and lab testing shows there's a drop in this. So it sounds like HIT, right? So what do? You take them off heparin and you start them on direct thrombin inhibitors, fondaparinux, argatroban, or Willebrand, I'm guessing. And then there's this other question. A 33-year-old, it's probably for this one, but let's go through it as well. A 33-year-old woman was admitted to the hospital for anticoagulation after a pulmonary embolism. 33 women, hospital for anticoagulation after pulmonary embolism. On day 4 of her stay, her platelet level decreased from 15,000 to 60,000, and her INR remains less than 2. What is the next best step, and what complications can result from this condition? So again, she had pulmonary embolism, so they gave her heparin for it, and then now she has this. So what is the next best step? Same thing, I'm guessing. Let's see. This patient has HIT type 1. The best next step is to discontinue heparin immediately and treat the DVT with a direct thrombin inhibitor. For the lady, this patient is experiencing HIT, which occurs secondary to formation of antibodies that activate platelets. So this was type 2, okay. Because HIT can lead to hypercoagulable state and subsequent thrombotic complication, heparin must be stopped immediately and the patient must be switched to argatroban, this. Okay, so treatment is the same for both. Yes. And yes. Okay. So antiphospholipid syndrome. Antiphospholipid syndrome is often associated with systemic lupus erythematosus, or SLE, 20% to 30%. and rheumatoid arthritis. The main antiphospholipid syndrome antibodies are the lupus anticoagulant, anti-beta 2 glycoprotein, and anticardiolipin. APS predisposes to both arterial and venous thrombi formation and spontaneous abortion, particularly associated with anticardiolipin antibodies. Lab testing shows a paradoxically prolonged PTT, only thrombophilia with a abnormality in PTT. So again, gotta read that again. So antiphospholipid predisposes to both arterial and venous thrombi formation and spontaneous abortion, particularly associated with anticardiolipin antibodies. Lab testing shows a paradoxically prolonged PTT. Okay. Only thrombophilia with an abnormality in the PTT. So this is normally this should be lower, and if there's clots being made, right? But for this one, you get longer PTT, and it seems like there are no clots being made, but here it is a hypercoagulable state. So that's why it's called paradoxically prolonged. And it's the only thrombophilia or hypercoagulable state with an abnormality in the PTT. Okay. History and physical examination. Antiphospholipid syndrome. Most commonly in young and middle-aged female with recurrent miscarriages and thrombosis. Could have a history suggestive of SLE with photosensitivity, oral ulcers, patchy hair loss, and Raynaud phenomenon. Raynaud, patchy hair loss, oral ulcers, photosensitivity. So these are all your SLE suggestions. Okay. Diagnosis. Diagnostic criteria for APS: at least one clinical and one lab criterion need to be met. So clinical criteria is evidence of vascular thrombosis event, any of the following pregnancy complications, more than one spontaneous abortion, one or more, spontaneous abortion of a normal fetus at or beyond 10-week gestational age, one or more premature births of a morphologically normal neonate before 34 weeks of gestational age, 3 or more unexplained consecutive spontaneous abortions before 10 weeks of gestational age, unexplained by any maternal or paternal causes, anatomic, chromosomal, or hormonal. Lab criterion is that it needs to have detection of lupus anticoagulant or anti-beta 2 glycoprotein 1 antibody or anticardiolipin antibody on 2 or more occasions at least 2 weeks apart. Lab testing showing a paradoxically prolonged PTT and normal PT. PTT does not correct with a mixing study due to the presence of antibodies. The addition of excess phospholipids can correct the prolonged PTT. Disease-specific test for APS is lupus anticoagulant and anticardiolipin antibodies. Key factor is that in patients with recent exposure to warfarin who are experiencing warfarin-induced skin necrosis, the physician should suspect protein C or S deficiency. Okie dokie. Treatment here is for vascular events, treatment with lower molecular weight heparin in APS, or unfractioned heparin and a bridge to warfarin until INR is in the therapeutic range. May require lifelong anticoagulation with warfarin. Direct oral anticoagulants are less effective in antiphospholipids. Okay, so we don't give those. Don't give your agatroban, fondaparinux, thrombin inhibitors. So you give low molecular weight heparin or unfractioned heparin in APS and bridge to warfarin until INR is in the therapeutic range. Thromboprophylaxis is controversial in APS in the absence of vascular events. Okay. Water break. Okay. So what the patient has type 1. Okay. These are from these two. Okay. DIC. Key fact. DIC is characterized by both thrombosis and hemorrhage. Yes. Let's take a break here. All right. So we were at disseminated intravascular coagulation. An acquired coagulopathy caused by deposition of fibrin in small blood vessels leading to thrombosis and end organ damage. Depletion of clotting factors and platelets lead to it bleeding diathesis. Okay, so depletion of clotting factors and platelets lead to this. Okay. It's caused by deposition of fibrin in small blood vessels, leading to thrombosis and organ damage. It is associated with many severe illnesses and is often seen in hospitalized patients. Disseminated intravascular coagulation can be acute or chronic. This patient has HIT type 1. Oh, no, sorry, we already did that. Disseminated intravascular coagulation can be acute or chronic. History and physical examination. Some common causes of DIC can be found in table 2.7.7. We'll do that. Clinical presentation. Acute DIC is observed with a recent history of trauma or sepsis or in patients with a history of ABO incompatible blood transfusions. It presents with bleeding, low platelet count, and plasma fibrinogen, and a prolonged PT, PTT, and D dimer. Okay, so that one and prolonged both of these, low platelet count, and low plasma fibrinogen. It presents with bleeding, and it's observed in history of trauma or sepsis or in patients with history of ABO incompatible blood transfusion. Common etiologies of DIC. OBS complication, for example, amniotic fluid embolism, aberratio placenta, malignancy like acute promyelocytic leukemia, APL, pancreatic cancer, or acute respiratory distress syndrome, ARDS, pancreatitis, or burns. So in OBS complication, it's a vascular disorder. Okay, so that's different. Aortic aneurysm, systemic disorders like sepsis, transfusion reactions, transplant rejections, hemolysis, drug reactions, acidosis. Others are massive trauma and snake bites. Okay, so we did acute DIC. It also presents with shock and multi-organ dysfunction like renal dysfunction, hepatic dysfunction, and transient neurologic syndromes. Bleeding from venipuncture sites into organs and ecchymosis and patagy. Chronic DIC is observed in patients with a chronic history of cancer, normal to low platelet count, normal to mildly high PT, PTT, and fibrinogen, and elevated D dimer. Okay. So I was this different than the other one. So this is normal to low platelet count, normal to mildly high PT, PTT, and fibrinogen. Okay. Whereas in this one we had low platelet count and low plasma fibrinogen, and prolonged PTT and PT and D dimer. Okay. But here also we have elevated D dimers. It is often asymptomatic and can present with laboratory changes only. It can also present with venous and arterial thromboembolism without an identifiable precipitating factor. Okay, key fact here is DIC is characterized by both thrombosis and hemorrhage. Diagnosis. Lab test: increase in PT and PTT, decrease in platelets, increase in D-dimer and fibrin, and decrease in fibrinogen. Okay, so increase in fibrin and D-dimer and decrease in fibrinogen. Possibility of DIC to be confused with liver disease. Unlike liver disease, factor 8 is depressed in DIC. Treatment here is treatment for the underlying cause, transfusion of RBCs, platelet, and fresh frozen plasma, and management of shock as necessary. Platelet disorders: thrombotic thrombocytopenic purpura, TTP. Thrombotic thrombocytopenic purpura, TTP, is a deficiency of the 1 Willebrand factor cleaving enzyme, ADAMTS13, resulting in abnormally large 1 Willebrand factor multimers that aggregate platelets and create platelet microthrombi. These block small blood vessels, leading to an end organ damage. RBCs are fragmented by contact with the microthrombi, leading to hemolysis, microangiopathic hemolytic anemia, and thrombocytopenia. TTP is medical emergency and can be immune-mediated or hereditary. Okay, so again, I'll read that one more time. Deficiency of 1 Willebrand cleaving enzymes, resulting in abnormally large 1 Willebrand factor multimers that aggregate platelets and create platelet microthrombi. These block small blood vessels, leading to end organ damage. RBCs are fragmented by the contact with the microthrombi, leading to hemolysis and thrombocytopenia, and it is a medical emergency and can be immune-mediated or hereditary. History and physical examination: TTP associated with SLE, malignancy, pregnancy, cyclosporin, quinidine, clopidogrel, ticlodipine, and AIDS. Thrombotic thrombocytopenic purpura can also be hereditary. Classic description involves a pentaid of features. The physician should suspect TTP if 3 or 5 of the following symptoms are present. LMNOP. L for low platelet count, thrombocytopenia. M for microangiopathic hemolytic anemia and cysticercosis. Severe, often with jaundice. You see this in HUS as well, right? And this as well. Or no. That. Neurologic changes: delirium, seizures, stroke, decrease in consciousness, and decrease in vision. So CNS symptoms. Obsolete, impaired. O for obsolete, okay. Impaired renal function, acute kidney injury, and then pyrexia or fever. Okay. Okay, so in HUS you didn't have CNS and fever, I believe, but you had the triad, which was what was it? Hemolytic anemia, low platelet count, and right. So the triad of thrombocytopenia, anemia, acute kidney injury, plus bloody diarrhea, whereas here you have triad plus fever and neurologic symptoms. Okay. Diagnosis. General workup of thrombocytopenia can be found in figure 2.7-4 right there. Okay. So lab test, decrease in platelet, decrease in hemoglobin because of anemia, increase in creatinine because of AKI, normal clotting, coagulation screen. PT, PTT, and fibrinogen are normal, which is different from the coagulation profile observed in DIC. In addition, due to hemolysis, lactate dehydrogenase (LDH) and indirect bilirubin are increased, while haptoglobin is decreased. Okay, so that's new. Why is haptoglobin decreased? Because of the hemolysis that happens, all the RBCs leak out the hemoglobin, and hemoglobin then attaches to the haptoglobin. So the free haptoglobin decreases. Okay, blood film, presence of schistocytosis, schistocytes, fragmented RBCs. And most accurate diagnostic test is measure of Adams TS13 activity. Okay, why? Because again, you have deficiency of it. Okay, so here you have thrombocytopenia, platelets less than 150,000. So you check CBC. If CBC and WBC are normal, then you evaluate for hemolysis. So peripheral fragmented RBCs are seen, or schistocytes. The lab work will show there's increase in indirect bilirubin, D-dimer, fibrinogen, PT, PTT, and LDH. There will be decreased haptoglobin. If this is correct, then you have increased destruction of macroangiopathic hemolytic anemia, mechanical, which is prosthetic valve, or vegetation. If this is not there, then you have this increase in destruction due to antibody mediated, or ITP, or HIT, or it could be because of decrease in production like nutritional deficiencies or medications, or redistribution like dilution or sequestration. You check the CBC, but it's abnormal, like decreased RBC and WBC, then pursue bone marrow biopsy. Okay, treatment here is plasma exchange is the best initial treatment. Steroid and rituximab can be added to decrease microthrombus formation. Platelet transfusion is contraindicated in TTP as additional platelets are consumed by the disease process, potentially worsening the patient's condition. HUS, or hemolytic uremic syndrome. Hemolytic uremic syndrome, or HUS, and TTP have overlapping clinical manifestations and are considered a spectrum of the same disease that is caused by Adams TS13 deficiency, which is either inherited or often acquired secondary to infection. TTP is more common in adults, and HUS is frequently seen in children, associated with E. coli 015787. HUS can present similarly to TTP with the absence of neurologic features. More than 90% of cases in children are caused by E. coli 015787, hemorrhagic diarrhea, which precedes the syndrome. The E. coli infection is triggered by eating undercooked, contaminated meat. Characterized by renal failure, microangiopathic hemolytic anemia, and low platelet without neurologic symptoms, abdominal pain, bloody diarrhea, and AKI often seen. Severe increase in creatinine levels is more typical of HUS than TTP. Okay, so severe increase in creatinine levels is more typical of HUS than TTP. Abdominal pain, bloody diarrhea, AKI. Schistocytes, fragmented RBC seen in both HUS and TTP. Okay, water break. So here we have helmet cells or schistocytes right here. These fragmented RBCs can be seen in microangiopathic hemolytic anemia and in mechanical hemolysis, such as that due to artificial heart valves. Okay. Diagnosis. Lab test. Decrease in platelets. How does this differ from this one? Let's see. Okay, so lab test. Decrease in platelets, decrease in hemoglobin, increase in creatinine. So far it's the same. Normal clotting coagulation screen. PT, PTT, and fibrinogen are normal, which is different from the coagulation profile observed in DIC. Okay, that was a copy paste. In addition, due to hemolysis, LDH and indirect bilirubin are increased, whereas heptoglobin is decreased. Okay, this is deja vu now. Blood film, presence of schistocytes, fragmented RBCs. Okay, so that right there. Okay. Okay, so that was just copy paste. Treatment is HUS. Dialysis for AKI may be needed. Plasma exchange is used for severe persistent disease. Antibiotics and antimotility drugs such as anticholinergics are not recommended, as they have been shown to increase the likelihood of HUS resulting from E. coli 0157H7. One other key point is that hydration can help reduce the risk of AKI. Platelet transfusion is contraindicated in HUS, as additional platelets are consumed by the disease process, potentially worsening the patient's condition. A summary of the clinical and lab findings seen in TTP, HUS, and DIC can be found here. And the common lab features seen in different bleeding disorders can be seen in there. Okay, so let's go through the table. Summary of clinical and lab features of TTP, HUS, and DIC. Pathogenesis here are in TTP, it's acquired or hereditary deficient 1 Willebrand factor cleaving enzyme AMTS13. Age group adults 20 to 50 years of age. Peripheral smear will show schistocyte. Microangiopathic hemolytic anemia. Yep. Platelet is low. PT is normal. PTT is normal. Fibrinogen is normal. D-dimer is normal. However, that was not the case when we were reading this, right? All of these were... Oh, okay, they're talking about this one. Yeah, PT, PTT. Whoops. Platelet is low. PT, PTT, fibrinogen, and D-dimer are normal here. Create is... Platelet is low. Hemoglobin, okay. And create. Cool. Create is increased. Renal dysfunction symptoms. There will be CNS, yes, severe, and fever. Management is plasma exchange and steroids. For HUS, it's toxin-induced endothelial damage, often due to E. coli 0157H7 variety. Age group, children less than 5 years of age. Peripheral smear is schistocyte. MAHA is yes. Platelet is low. PT is normal. PTT is normal. Fibrinogen is normal. D-dimer is normal. Create is increased because of renal failure. Symptoms is CNS maybe, mild, but definitely diarrhea, and usually it's bloody. MAHA is, management is supportive. Here the management was all of this stuff. Okay, so in severe you can use plasma exchange. Antibiotics, antimotility is supportive, I guess. Oh no, it's not recommended, my bad. So don't give antibiotics. as they have been shown to increase the likelihood of HUS resulting from this. Okay, platelet transfusion is also contraindicated in HUS. DIC, so uncontrolled activation of coagulation and fibrinolysis. Consumption coagulopathy, age group, you see it in all types. Blood smear or peripheral smear is schistocytes. You will see MAHA. Platelets are low. PT is prolonged. PTT is prolonged. Fibrinogen is low. And D-dimer is high. Okay. Create is normal to increased. Symptoms is CNS possible, and multi-organ failure is there. Management is treat underlying cause like sepsis or cryoprecipitate transfusion and supportive care. An 80-year-old girl presents to the emergency department with 2 days of fever, vomiting, bloody diarrhea, and irritability. She began feeling unwell after attending a classmate's birthday party. Lab results show thrombocytopenia, increase in create level, and schistocytes. What is the next best step? Give supportive care, I'm guessing. HUS is the most common cause of acute renal failure in children. Supportive therapy includes IV fluids, blood pressure control, blood transfusion, and, if necessary, dialysis. Antibiotics are not indicated as they are thought to decrease expulsion of the toxin and may increase toxin from the destruction of bacteria. Okay. Now let's talk about the lab features of bleeding disorders. Okay, so now we have everything in one diagram here. So we will go through thrombocytopenia, 1 Willebrand disease, hemophilia, vitamin K deficiency, liver disease, and DIC. Okay, so in thrombocytopenia means low platelets, so platelet count will be low. If platelet count is low, that means bleeding time is increased. Everything else is going to be normal. PT, PTT, fibrinogen, and D-dimer. 1 Willebrand disease, again, you have platelet count which is normal, but bleeding time will still be prolonged because there is no platelet aggregation there at the site of exposed collagen. PT is normal, PTT is normal because clotting factors are still working and they're fine. PTT, however, it could be prolonged if factor 8 is decreased, which stimulates or is associated with 1 Willebrand factor. Fibrinogen is going to be normal, D-dimer is normal. Hemophilia, platelet count is normal, bleeding time is normal. PT is normal because that is extrinsic factors. However, because this is related to factor 8, PTT is going to be prolonged. Fibrinogen is normal and D-dimer is normal. Vitamin K deficiency, so now these are your factor 1972 or 10, 9, 7, and 2, and CNS. Your platelet count is not going to be affected by these, so it's going to be normal. Bleeding time, if platelets are normal, bleeding time is normal. PT is going to be prolonged because of factor 7, and PTT is going to be prolonged because of all the other factors that are not being activated. Fibrinogen is normal, D-dimer is normal. Okay, liver disease. Platelet count is going to be low to normal. Bleeding time is normal. PTT is prolonged, PT is prolonged, fibrinogen is normal, D-dimer is normal. Okay, DIC is going to be low in platelet count, bleeding time is going to be prolonged, PT is going to be prolonged, PTT is going to be prolonged, fibrinogen is low, and D-dimer is high. So this is basically a picture of when shit hits the fan. Idiopathic thrombocytopenic purpura ITP. Immunoglobulin G antibodies are formed against the membrane protein GP 1 B and it should be 2B. Okay, so GP2B and 3A of platelets. The platelet antibody complex is destroyed by the spleen. Bone marrow production of platelet is increased and increased megakaryocytes in the marrow. It is the most common immunologic disorder in females of childbearing age. Okay. Water break. Okay. DJ, rewind that. Okay. IgG antibodies are formed against the membrane protein GP2B3A of platelets. Okay, so antibodies are against that. The platelet antibody complex is destroyed by the spleen. Okay. Bone marrow production of the platelets is increased with increased megakaryocytes in the marrow. It is the most common immunologic disorder in females of childbearing age. History and physical examination. Patients often feel well with no systemic symptoms. They may have minor mucocutaneous bleeding, easy bruising, patachi, hematuria, or melena. Generally, there is no splenomegaly. Splenomegaly can also cause platelet sequestration, resulting in thrombocytopenia, generally seen in myeloproliferative disorder, infections like malaria, and visceral leishmaniasis. Okay. Since I was zoned out, I'm going to read that again. Patients often feel well with no systemic symptoms. They may have minor mucocutaneous bleeding, easy bruising, patachi, hematuria, or melena. Generally, there is no splenomegaly. Okay. Why? Splenomegaly can also cause platelet sequestration, resulting in thrombocytopenia, generally seen in myeloproliferative disorder. Infections like malaria and visceral leishmaniasis. Oh, okay. So here we don't see splenomegaly. When we see splenomegaly and you have low platelets, it's generally seen in myeloproliferative disorders or infections like malaria and visceral leishmaniasis. Okay, got it. ITP is associated with a range of conditions including malignancies like lymphoma and leukemia, autoimmune disorders, SLE, and viral infections. HIV, Hep C, and can present acutely or as a chronic illness. Acute. Abrupt onset of hemorrhagic complications occurs after a viral illness with sudden, self-limiting purpura. It commonly affects children 2 to 6 years of age, with boys and girls affected equally. Okay, so if it's acute, it's abrupt onset of hemorrhagic complications occurring after a viral illness with a sudden self-limiting purpura. So the history is important over there if you're going to pick this as an answer. It commonly affects children 2 to 6 years of age, with boys and girls affected equally. Okay, so acute one is in children, ITP. Chronic, insidious onset of symptoms occurs, or CBC shows incidental thrombocytopenia. Okay. There is fluctuating course of bleeding, purpura, epistaxis, and menorrhagia. It affects adults 20 to 40 years of age and females more than males. Diagnosis. The diagnosis is one of exclusion. Once other cause of thrombocytopenia have been ruled out, diagnosis can occur via history and physical examination, a CBC, and a peripheral blood smear showing megakaryocytes and normal RBC morphology. It is important to rule out pseudothrombocytopenia due to platelet clumping by ethylene dimethylated acetic acid, or EDTA, in test tubes. Antiplatelet antibodies are often present. Antiplatelet antibodies are often present. Bone marrow biopsy would also show increased megakaryocytes, but is done only in atypical cases of patients more than 60 years of age. Additional tests for all patients with ITP include HIV. 5 to 10% of chronic HIV patients may present with isolated thrombocytopenia, Hep C, H. pylori, direct anticoagulation test, and blood type. So treatment here is platelet count for more than 30,000 and no bleeding. There's no treatment required. Platelet count less than 30,000 or clinically significant bleeding symptoms, corticosteroids or intravenous immunoglobulin, so IVIG. Okay, for less than 30. If platelet count fails to improve or bleeding recurs, the physician should consider splenectomy, with or without rituximab, with or without thrombopoietin TPO receptor agonists to increase platelet production. That is romiplostim or eltrombopag. Okay, I think that was for the thrombin analog, or okay. Platelet transfusion are not used except during splenectomy or life-threatening hemorrhage, as the platelets are quickly destroyed by antibodies caused by HCV, Hep C virus, or HIV. Treatment of the underlying infection can improve platelet count. In pregnant patients, severe thrombocytopenia may occur in the fetus. Key fact here is anti-D or H immunoglobulin and rituximab are second-line therapies for ITP. Anti-D or Rh immunoglobulin and IVIG act as decoys so that WBCs will recognize them instead of IgG on platelets. Key fact here is steroid-sparing therapies are generally agents used as alternatives to avoid steroid-related adverse events such as high blood sugar and osteoporosis. Okay. Red blood cell disorders, anemias. Okay, anemias, disorders of low hematocrit and hemoglobin. Subtype are classified according to RBC's main corpuscular volume and reticulocyte count. Anemias, microcytic, MCV less than 80 is going to be hemoglobin defects. That's your tail for thalassemia, anemia of chronic disease, iron deficiency anemia, and this is late, and lead poisoning, and the odd one out is sideroblastic anemia. Okay. The normocytic is going to be MCV is 80 to 100. So if you have those, then you look at reticulocyte count. If it's given and it's less than 2%, that means new RBCs, immature RBCs are less, and mature ones are more if it's more than 2%. So if it's less, that means new ones are not being made as much. So it could be because of iron deficiency in early, anemia of chronic disease, aplastic anemia, or chronic kidney disease. If reticulocyte count is more than 2%, then you look at if it's intrinsic or extrinsic causes. Intrinsic causes are membrane defects. That means it's because of how the RBC is made. It could be membrane defect, it could be enzyme deficiency or hemoglobinopathies. So membrane defect, it could be hereditary spherocytosis or paroxysmal nocturnal hemoglobin. That's the one with CD54, 55 antibodies against those. And you get nocturnal hemoglobinuria. Right. Enzyme deficiencies is G6PD deficiency, pyruvate kinase deficiency. Hemoglobinopathies are sickle cell anemia and hemoglobin C disease. If reticulocyte count is more than 2 and you're looking at extrinsic reasons, it could be autoimmune, microangiopathic, macroangiopathic, hemolytic anemia, or infections. If it's anemia and MCV is more than 100, it's called macrocytic. Then you got to differentiate between megaloblastic or non-megaloblastic. And megaloblastic nuclear defects will include defective DNA synthesis, so that's because of folate deficiency or vitamin B12 deficiency or orotic aciduria, and it could be because of defective DNA repair like Fanconi anemia. If it's non-megaloblastic, then it could be because of Diamond-Blackfan anemia, liver disease, or alcoholism. And we'll go through those now. Water break. Okay. Koilonychia is spoon nails. That's what it looks like. The finger plate, nail plate is concave. Okay, so microcytic anemias, iron deficiency anemia, occurs due to increased demand, for example, growing period, pregnancy, erythropoietin therapy, or decreased iron due to chronic bleeding, like menorrhagia, GI loss, malnutrition, absorption disorder, for example, celiac disease, and GI surgery, for example, gastrectomy. Toddlers, adolescent females, and females of reproductive age constitute high-risk groups. History or physical examination. Symptoms of fatigue, dyspnea, tachycardia, angina, syncope, and pica. Pica is persistent craving and compulsive eating of non-food substance. Okay. So fatigue, dyspnea, tachycardia, angina, syncope, and pica. Physical findings will be glossitis, chillosis, conjunctival pallor, and koilonychia, spoon nails. Plummer-Vinson syndrome, triad of iron deficiency anemia, esophageal webs, and dysphagia. Key fact here is microcytic anemias or microcytosis have a low MCV, less than 80, and generally have a low reticulocyte count. Okay. Diagnosis, best initial test is CBC. So you will see that there is decrease in MCV, decrease in mean corpuscular hemoglobin or MCH, decrease in mean corpuscular hemoglobin concentration MCHC with iron profile given over here. Iron deficiency anemia should be distinguished from thalassemia and anemia of chronic disease. Most accurate test is bone marrow iron stain, Persian blue stain to be exact. Peripheral blood smear can show microcytic, hypochromic RBCs, and with anisocytosis, poikilocytosis, and low reticulocyte count. Treatment is iron supplementation. Oral iron is preferred over IV iron. Duration of oral iron replacement to replenish stores depends on iron deficit, 6 weeks to 6 months. Oral iron may lead to nausea, constipation, diarrhea, abdominal pain, and black stools. Alternate day therapy can minimize GI adverse effects. Antacids may interfere with iron absorption. Okay. Again, oral iron may lead to nausea, constipation, diarrhea, abdominal pain, and black stools. So that alternate day therapy can minimize GI adverse effects. So every other day or every 3 days. Antacids may interfere with iron absorption. Key factor here is iron deficiency anemia in an older adult patient may be caused by colorectal cancer until proven otherwise and must therefore be evaluated to rule out malignancy. Mnemonic here, cause of microcytic anemia is iron last. Iron deficiency last is lead poisoning, anemia of chronic disease, sideroblastic anemia, and thalassemia. I like mine better. Tails. Thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, and sideroblastic anemia. Okay, and iron deficiency anemia. Note the microcytic hypochromic RBCs over there. Donut cells with enlarged area of central pallor. Okay, iron deficiency anemia versus anemia of chronic disease versus thalassemia. Iron deficiency, serum iron is decreased. Total iron binding capacity, because we want more, it's going to be increased. Ferritin, the storage of iron, is going to be decreased. Transferrin saturation is transport, I believe. Hold on, let me check. Protein of the beta globin group which binds and transports iron into bloodstream, right? So transferrin saturated by iron is going to be decreased. Red cell distribution width is going to be increased. Peripheral smears, microcytosis, and hyperchromia. Response to iron supplementation is going to be increased hemoglobin. Okay. In anemia of chronic disease, serum iron is going to be less because we don't want it. I believe it was that bacteria want these things, so we hide it from them. So serum iron is going to be decreased. Total iron binding capacity is going to be decreased because we don't want more iron in the body for the bacteria to use. The storage form of iron is going to be all increased because all of our iron is going to be in storage. Percent transferrin saturation is going to be normal or decreased because iron is not really being transported at the moment, and it will get to you in 2 to 3 business days. Our red cell distribution width is going to be normal. Peripheral smear is going to be that you're going to start seeing target cells there. Okay. Response to iron supplementation is no improvement. So there's no point of giving iron if it's because of iron deficiency anemia. Okay, thalassemia trait. If you have thalassemia trait, serum iron is going to be increased. You have iron there. Your total iron binding capacity is going to be decreased because they don't need it because they already have iron, so you don't need more iron. So binding capacity is going to be decreased. Ferritin, the storage form of iron is going to be good. Percent transferrin saturation, they're also going to be there. Everything is going to be normal. Red cell distribution width is going to be normal. However, peripheral smear, you can be seeing target cell with or without target cell there. Response to iron supplementation, there's no improvement there. Okay. IV iron is preferred. Where are we taking that from? Okay, treatment. So IV iron is preferred if the oral route is ineffective. For example, gluten sensitivity, inflammatory bowel disease, GI malabsorption, post-gastric bypass surgery, hyperemias, emesis gravidarum, and a history of oral iron intolerance. IV iron is superior to oral iron in achieving a sustained hemoglobin response, reducing the need for packed RBC transfusion and improving the quality of life for patients with chronic heart failure, inflammatory bowel disease, chronic kidney disease, and hemodialysis and cancer-related anemias. IV iron dextran is associated with a small risk for serious adverse effects, including anaphylaxis. Iron sucrose can be associated with a lower risk for allergy. Key fact here is anemia secondary to end-stage renal disease is caused by deficiency of EPO. Treatment with recombinant EPO is effective but often leads to worsening of hypertension. Anemia of chronic inflammation disease or chronic disease or chronic inflammation. To limit bacterial proliferation, the body hides or locks its iron in situations of chronic inflammation such as infection, malignancy, rheumatoid arthritis, or SLE. Iron is trapped in macrophages or in ferritin. Increase in inflammation when it's trapped in ferritin. So if there's increase in inflammation like RA, it's going to be found more in ferritin. This results in a microcytic or normocytic anemia with normal or increased levels of iron storage in the form of ferritin, but decreased serum iron and decreased total iron binding capacity, TIBC. Treatment consists of treating the underlying disease, anemia associated with end-stage renal disease, ESRD. Response to EPO replacement once iron stores have been depleted. Lead poisoning. But you know what I'm going to do now? Drink water. Alright. Lead poisoning inhibits ferrochelatase and aminolevulinic acid or ALA dehydratase, decrease in heme synthesis and increase in RBC protoporphyrin. There used to be a thing for this. Let me see. Okay. I think this is dirty medicine video. Okay, let's take that. Okay, so we have ALA coming in. This is lead poisoning over here. Okay, so it inhibits. So when you have lead poisoning, it inhibits ferrochelatase and aminolevulinic acid right here. Dehydratase will lead to decrease in heme synthesis. Okay, so it inhibits this and it inhibits this, or dehydratase that. Sorry. Okay, right there. So that and that. So that will lead to decrease in heme synthesis and increase in RBC protoporphyrin. Right. Okay. So that's porphyrin, and I believe it's somewhere there where there is protoporphyrin as well. Oh, there you go. There it is. Whoops. Okay, and increase. So we have increase of this because of this, and we have increase in what? That. Okay, that's it. Whew. Also inhibits ribosomal RNA or degradation. Okay. RBCs retain aggregates of rRNA, basophilic stippling, ribosomal RNA, sorry. Right. So RBCs retain aggregates of ribosomal RNA, basophilic stippling. Exposure risks increase in adults because of inhalation during industrial work like battery factory, and in children because of eating lead paint, old house with chip paint built before 1978. History and physical examination. Symptoms of lead poisoning include lead. So lead for L4, lead lines on gingiva or Burton lines, and on metaphysis of long bones on X-ray, encephalopathy and erythrocyte basophilic stippling. Excuse me. Abdominal pain, lead colic, and sideroblastic anemia, and drops, wrist and foot drops. Okay, so sideroblastic anemias, abdominal pain, encephalopathy, so CNS type symptoms. Erythrocyte basophilic stippling, you'll see lead lines on gingiva and metaphysis of long bones and drops. Okay, so that's basophilic stippling, and it's ribosomal RNA degradation. RBCs retain aggregates of ribosomal RNA, and that's your basophilic stippling. Lab findings are so ringed sideroblast, and this is basophilic stippling. Labs are will show decrease in hemoglobin and decrease in MCV. Treatment is removal from the exposure, chelation with the succimer, ADTA, and dimercaprol. These are your treatment for lead poisoning. Sideroblastic anemia occurs due to defective heme synthesis. Causes are genetic X-linked defect in elastase gene, acquired myelodysplastic syndrome, and reversible. Alcohol is most common and can suppress bone marrow. Also lead poisoning, vitamin B6 deficiency, copper deficiency, drugs like isoniazid and linezolid. So these are your reversible causes, and your acquired causes are myelodysplastic syndrome, and genetic causes are X-linked defect in elastase gene. Okay. History, physical examination, and labs. Presents with decrease in hemoglobin, decrease in MCV. Iron studies show iron overload, increase in serum iron, normal or decreased total iron binding capacity and storage form of iron. Ferritin is going to be increased. Peripheral blood smears shows basophilic stippling of RBCs and lead poisoning. Diagnosis is presence of ringed sideroblasts with iron lane Persian blue stained mitochondria on bone marrow smears. So you gotta remember, this one is seen in bone marrow samples. This is peripheral smear samples. Okay. So when you see ring sideroblast with iron lane Persian blue stained mitochondria on bone marrow smear is diagnostic. Treatment here is of the underlying cause. Treatment of acquired causes with pyridoxine. Acquired cause was this myelodysplastic. So give vitamin B6 and cofactor for elastase. Right. So elastase cofactors for that. B6 is required. And that. Okay. This was the acute intermittent porphyria. This is the one with ectopain, and this one was the one with vampire because of the photosensitivity, I think. Or was that something else? Yeah, I think cutaneous tarda, right? Porphyria. Okay. alpha thalassemia and beta thalassemia. So in alpha thalassemia minima, you have one gene affected. In minor, cis is both genes affected serially, and here in trans, it's parallel genes affected too. Hemoglobin H is when 3 genes are affected, alpha, and Bart's when all of the alpha genes are affected. Beta thalassemia is minor or major. So minor is one gene affected in beta gene, or both the beta genes are affected. Cis are this, trans, H, and Bart. Okay. Thalassemia, hereditary disorder involving decrease of absent production of normal globin chain of hemoglobin. Alpha thalassemia is caused by a gene deletion of one or more of the 4 genes that encode alpha hemoglobin. Beta thalassemia results from a point mutation. Okay, so this is a point mutation. And alpha thalassemia is caused by gene deletion. Okay, so that's the difference between the two. Okay, point mutation of one or both of the 2 genes encoding beta hemoglobin. History or physical examination. Thalassemia is most common among people of African, Middle Eastern, and Asian descent. Disease presentation varies with the number of genes missing. Sorry. A typical case can be an asymptomatic or fatigued individual with a microcytic anemia and normal iron studies. Diagnosis: most accurate test is hemoglobin electrophoresis. Normal in alpha trait, alpha silent carrier. For alpha thalassemia, genetic studies are the most accurate tests. Okay, so most accurate test is hemoglobin HB electrophoresis. It's normal in alpha trait and alpha silent carrier. For alpha thalassemia, genetic studies are most accurate. All forms of thalassemia have a normal red cell distribution with only 3 gene deletion. Alpha thalassemia, or HBH, is associated with HBH and increased reticulocyte count. Key fact here is Metzer index. MCV divided by RBC count, or so MCV divided by RBC, can help distinguish between thalassemia and iron deficiency anemia. Metzer index less than 13 suggests thalassemia, and more than 13 suggests iron deficiency anemia. Okay, so Metzer index less than 13 suggests thalassemia, more than 13 suggests iron deficiency anemia. Interesting. Treatment is most people do not require treatment. Trait is not treated. So those with beta thalassemia major and HB hemoglobin H disease are often transfusion dependent, chronic lifelong transfusion, and require oral chelators like Deferasirox and Deferiprone, or so that's again Fe for iron and Fe for iron chelators, or a parenteral iron chelator, deferoxamine, to prevent overload. Right. Okay. Differential diagnosis of thalassemias. So subtype, number of gene present, and clinical features. Subtype: beta thalassemia, major or Cooley anemia. Okay. Right. So beta thalassemia, major Cooley anemia. Number of genes present is 0 or 2 beta. Okay. Oh, sorry. Okay. So 0 out of 2 betas genes are present. So that's called your beta thalassemia major, and it's called Cooley anemia. Sorry, I was zoned out. Clinical features is if patients develop severe microcytic anemia and failure to thrive during late infancy, 6 to 12 months due to hemoglobin F to hemoglobin A transition. Patients need lifelong chronic transfusions or marrow transplant to survive. Extramedullary hemopoiesis occurs in response to anemia, for example, skull bossing or hepatosplenomegaly. So, if you have seen patients of uh, these in your, I don't know, pedia rotations or something, you'll see that their heads were this skull bossing. So, let's see what that looks like. Okay. Like that. In adults, it's not as prominent, and but yeah, like that right there. Okay, and you'll see hepatosplenomegaly. Okay, so again, patients develop severe microcytic anemia and failure to thrive during late infancy, 6 to 12 months, due to hemoglobin F to HbA transition. Patients need lifelong chronic transfusion or marrow transplant to survive. Extramedullary hematopoiesis occurs in response to anemia. Then you have 1 out of 2 beta chain that's called beta thalassemia minor, because we saw that over here. The minor is you only have one. Patients are asymptomatic with mild to moderate and well tolerated anemia, but their cells are microcytic and hypochromic on peripheral smear. This disease is often confused with iron deficiency anemia. It is common among people of Mediterranean descent. So if they're from like Greece, think thalassemia. If they're iron deficient, or everything seems like that. So patients are asymptomatic, mild to moderate, and well tolerated anemia, but their cells are microcytic and microchromic. Whoops. Okay, hydrophytalis. This is parts when you have 0 out of 4 alpha genes. Fetal demise in utero. Okay, that was short. Hemoglobin H disease, 1 out of 4 alpha. Patients have severe hypochromic microcytic anemia and chronic hemolysis, splenomegaly, jaundice, and cholelithiasis. The reticulocyte count increase to compensate, and 1/3 of the patients have skeletal changes caused by expanded erythropoiesis. Okay, so when you have 1 out of 4, right? Oops. Right, so that was this. So patients have severe hypochromic microcytic anemia with chronic hemolysis, splenomegaly. Again, this is splenomegaly. This will cause it. This doesn't cause it, but this will cause it. Okay. Jaundice and cholelithiasis. The reticulocyte count is increased to compensate, and 1/3 of the patients have skeletal changes caused by expanded erythropoiesis. Okay, so again, all of these might happen there as well. It's called Boston. Alpha thalassemia trait is 2 out of 4 alpha genes are there. Patients have low MCV but are usually asymptomatic, and silent carriers are 3 out of 4 alpha genes. Patients have no signs or symptoms of disease, normal clinical state. Key fact here is for this one. Okay, so let's take a break here. Okay. Non-hemolytic normocytic anemias, aplastic anemia, failure of blood cell production, pancytopenia caused by destruction of bone marrow cells. It may be hereditary, as in Fanconi anemia. Genetic anomaly analysis will show chromosomal breaks. Many have an autoimmune or viral etiology: HIV, parvovirus B19, Epstein-Barr virus, EBV, cytomegalovirus, CMV, hepatitis, or may result from exposure to toxins, cleaning solvents, insecticides, benzene, radiation, or drugs like sulfa, chloramphenicol, propylthiouracil, carbamazepine, alcohol, metamazole, and chemotherapy. Key factor is patients with Fanconi anemia can be identified on physical examination by cafe au lait spots, um, short stature, and radial thumb hypoplasia and aplasia. Uh, that's the one that's a dead giveaway. A 30-year-old man from Greece comes to the physician's office complaining of chronic fatigue. He has no significant past medical history and is on no medications. A CBC shows hemoglobin of 10 and MCV of 71, so that's microcytic. Um, the physician starts him on oral iron supplement and sees him back in 4 weeks with no change in CBC. What is the most likely diagnosis? Again, Greece, Mediterranean, thalassemia, right? So the most likely diagnosis is beta thalassemia minor. The physician should recognize that the patient has a microcytic anemia that did not respond to iron supplements. Probably has normal iron studies and is from Mediterranean. Okay. So history and PE of aplastic anemia. Patients are pancytopenic with symptoms resulting from a lack of RBCs, WBCs, and platelets, pallor, fatigue, weakness, a tendency of infection, pitachi, bruising, and bleeding. Diagnosis by clinical presentation and CBC. Most accurate test, bone marrow biopsy revealing hypocellularity and space occupied by fat. Okay, so that was pretty obvious when you saw it in like step 1 pictures in UWorld and FA. Diagnosis by clinical presentation, CBC. So this is again aplastic anemia is failure of blood cell production, so pancytopenia caused by destruction of bone marrow cells, right? So if you look into the bone marrow cells, you'll see the space is occupied by fat. Treatment is supportive therapy, blood transfusion for anemia, antibiotics for infection, platelets for bleeding. Okay, so you get blood transfusion for anemia, antibiotics for infection, and platelets if it's bleeding. Okay, and this is spherocytes. These RBCs lack areas of central pallor. Spherocytes are seen in autoimmune hemolysis and in hereditary spherocytosis. Okay. Supportive therapy, we did that. Consideration of allogenic bone marrow transplantations, BMT, in young patients with a matched donor. Some severe cases, patients without a stem cell donor or patients not suitable for bone marrow transplant, which is more than 50 years of age, call for immunosuppression with cyclosporine, anti-thymocyte globulin, and L-thrombobag to prevent autoimmune marrow destruction. Tacrolimus is an alternative to cyclosporine. Infections should be treated aggressively. Okay, so here we give transfusion, antibiotics, and this. Consideration for BMT. In some severe cases, they're not, BMT is not available, then you gotta do immunosuppression. So you use cyclosporine or antithymocyte, and this to prevent autoimmune marrow destruction. And tacrolimus is an alternative to cyclosporine. Infection treat aggressively. Hemolytic normocytic anemias. Here, Diamond-Blackfan syndrome presents with pure red cell aplasia and congenital anomalies such as triphalangeal thumbs and cleft lip. Okay. Hemolytic normocytic anemias occurs when bone marrow production is unable to compensate for increased destruction of circulating blood cells. Etiologies can be due to extrinsic or intrinsic hemolytic anemias as follows. Extrinsic hemolytic anemias, autoimmune hemolytic anemia, AIHA, microangiopathic hemolytic anemia, TTP, HUS, and DIC, macroangiopathic hemolytic anemias, prosthetic heart valves, aortic stenosis, hemolytic anemias due to infection, for example, malaria and babesia. Intrinsic hemolytic anemias are G6PD, deficiency, proximal nocturnal hemoglobinuria, hereditary spherocytosis, and sickle cell anemia. History and physical examination presents with pallor, fatigue, tachycardia, and tachypnea. Jaundice often presents too. Hepatosplenomegaly, pigmented gallstones, pigment, again, pigmented because the hemolysis, bilirubin, and all that. So pigment caused by increased indirect bilirubin, and leg ulcers because of poor blood flow may be noted. Okay, we have mnemonic for causes of hemolytic anemia. Mom passed me the glucose. So MOM, M for microangiopathic hemolytic anemia, that is TTP, HUS, DIC, others. O for others, malaria, hypersplenism. M for mechanical hemolysis. P for paroxysmal nocturnal hemoglobinuria. A for autoimmune anemia, sickle cell disease, spherocytosis, glucose 6 phosphate dehydrogenase deficiency. Diagnosis. So how do you diagnose this? The hemolytic normocytic anemias, again, it's the same thing. CBC, reticulocytes, electrolytes, liver function tests, haptoglobin, urinary urobilinogen. Decrease HCT, hematocrit, increase in LDH, increase in hematocrit bilirubin, increase in reticulocyte count, decrease in haptoglobin are commonly seen. Folate deficiency. Folate is used for increased cell production and hyperkalemia. Increased cell breakdown may be seen. Urine is dark with hemoglobinuria, and there is increased excretion of urinary and fecal urobilinogen. A slight increase in MCV, macrocytosis, is caused by large reticulocytes. Blood films. Hypochromic microcytic anemia, thalassemia, sickle cell anemia, cystocytes, microangiopathic hemolytic anemia, abnormal cells, so hematologic and malignancies, spherocytes, as in hereditary spherocytosis or autoimmune hemolytic anemia. Heinz bodies seen with supravital staining, and bite cells as seen in G6PD. Direct antiglobulin Coombs test to identify autoimmune hemolytic anemia. Treatment varies with the cause of hemolytic anemia, see later, but often includes corticosteroids to address immunologic causes and iron supplementations to replace losses. Splenectomy or transfusion are helpful in severe cases. Okay. G6PD deficiency. An X-linked recessive defect in G6PD causes the causing the inability to generate glutathione reductase, leaving RBCs susceptible to hemolytic anemia following oxidant stress. History and physical examination. Patients are often males of Mediterranean or African descent who present with sudden anemia, episodic dark urine, and jaundice, and who have a normal sized spleen with an infection or use drugs that induce oxidative damage to RBC. That was a long sentence. Patients are often males of Mediterranean or African descent who present with sudden anemia. You'll see episodic dark urine and jaundice, and who have normal sized spleen with an infection or use drugs that induce oxidative damage to RBCs. Common triggers include infections. Most common are fava beans, isoniazid, nitrofurantoin, um, dapsone, sulfa drugs, uh, TMP SMX, and antimalarials like quinines. I believe nitrofurantoin is the one used in UTI when they have sulfa allergy. Diagnosis, I apologize for that lawnmower outside, can't do anything about it. You're just gonna have to sit through it. Diagnosis is best initial test, CBC, with smears showing features of hemolysis with bite cells and Heinz bodies. Most accurate test is G6PD level 1 to 2 months after an episode, often normal during acute episode. Since G6PD deficient, RBCs are hemolyzed first. Okay, I couldn't hear my own thoughts there. I'm just gonna reread that. Best initial test is CBC with smears showing features of hemolysis with bite cells and Heinz bodies. A most accurate test is G6PD levels 1 to 2 months after an episode, often normal during acute episode. That's why we don't do it right away, since G6PD deficient RBCs are hemolyzed first. Key fact here is a classic presentation of G6PD deficiency is a black male patient presenting with fatigue, dark urine, and shortness of breath after taking TMP-SMX for a cold. Treatment is there is no reversal to the hemolysis. Avoiding triggers is the mainstay of treatment. Okay, mnemonic for causes of oxidative stress in G6PD is sell fava beans in India. Sulfa drugs, fava beans, infections, nitrofurantoin, dapsone, isoniazid, and antimalarials like quinines. Kidoki. Paroxysmal nocturnal hemoglobinuria, CD55 complement decaying accelerating factor, and CD59 membrane inhibitor of reactive lysis. Proteins normally found on the RBC surface protect them from complement-mediated hemolysis. Proximal nocturnal hemoglobinuria is a deficiency in glycosyl phosphatidyl inositol anchor molecules that inhibit CD55, CD59 attachment of or binding to RBCs. So since they don't have this, the CD55 and 59 are going to attach to RBC, and then that's going to cause hemolysis, so resulting in complement-mediated hemolysis and thrombosis. History and physical examination is going to show that paroxysmal nocturnal hemoglobinuria can manifest as iron deficiency anemia, episodic dark urine, venous thrombosis, most commonly mesenteric and hepatic vein thrombosis, pancytopenia, and abdominal pain. Diagnosis is most accurate diagnostic test is CD55, CD59 absence via flow cytometry. Okay, deficiency in this molecule that inhibits CD55 and 59. Oh, right, okay, sorry, I got that backwards. So CD55 and 59 are found on the RBC surfaces protect them from complement-mediated hemolysis. So now they don't have our deficiency in this molecule that inhibits this attachment or binding to this. Okay, wait, I'm confused. PNH is a deficient. I'm actually just going to go to this one and read it from here. Right, a defect in PIGA gene prevents the formation of glycosyl phosphatidyl inositol or GPI anchors from complement inhibitors, such as decaying accelerating factor, CD55, and membrane inhibitor reactive lysis, which is this, causing complement. Okay, so they prevent the formation of this anchor for complement inhibitors. Okay, so this is the one that is not found on RBCs, right? Or is not found. So then they don't attract CD55 and 59. So since these are not attacked, you get complements attacking the RBC. I think they got that backwards then, or I got it. Am I just being confused? Something's wrong here. So PNH is a deficiency in glycosyl phosphatidyl inositol anchor molecules that inhibit CD55-59 attachment. So it says that GPI molecules inhibit this attachment or binding to RBC, whereas here they're saying it's required, right, for complement inhibitors. And these are the complement inhibitors, such as decaying actor and this membrane inhibitor of reactive lysis, CD59. Since the complement inhibitors are not being binding to the anchors, that's why you get PNH. But here they're saying that PNH is deficient in GPI molecule that inhibit this attachment to this, resulting in complement-mediated hemolysis and thrombosis. Okay, we'll just learn it during UWorld, I guess. Which one is right? History and physical examination. PNH can manifest as iron deficiency anemia, episodic dark urine, venous thrombosis, most commonly mesenteric and hepatic vein thrombosis, pancytopenia, and abdominal pain. Diagnosis is, most accurate diagnostic test is CD55, CD59 absence via flow cytometry. So you won't find this, the complement inhibitors attached to RBCs. So that's how you would know. Treatment is, so again, this is, you do flow cytometry for PNH diagnosis. Treatment is prednisone. Prednisone is the best initial treatment. Allogenic bone marrow transplant is curative. Eculizumab, a complement inhibitor, can be used for hemolysis and thrombosis. Vaccination for Neisseria meningitidis needs to be administered for patients receiving eculizumab. Okay, so might be a question about a patient with PNH is, what other line of management would you do after prescribing eculizumab? Give vaccination for meningitis. Okay. Hereditary spherocytosis. Autosomal, it is an autosomal dominant defect or deficiency in spectrin or ankyrin and RBC and membrane protein, resulting in a loss of RBC membrane surface area and characteristic biconcave disc. RBCs are forced to take spherical shapes and are trapped and destroyed by the spleen. History or physical examination clinically presents as an extravascular hemolytic anemia with splenomegaly and jaundice. Acute cholecystitis from pigmented gallstones is a common complication. Okay, so again, autosomal dominant defect, or it could be deficiency in spectrin and ankyrin and RBC membrane protein, resulting in a loss of RBC membrane surface area. and characteristic concave disc. RBCs are forced to take spherical shapes and are trapped and destroyed by spleen. Here we have direct Coombs test and indirect Coombs test. So in direct Coombs test, we have the patient's component, which is RBC with or without anti-RBC antibodies, right, attached to them. And then anti-human globin or Coombs reagent is added. So it's like the anti-antibody, right? Okay, just two antis. So this RBC has antibody on it, and then this one has anti-antibody on it, in it, and then you mix it, and then if they coagulate, that means anti-RBC antibodies are present. Okay, and if they don't coagulate, that means the patient does not have any anti-RBC antibody in it. Indirect Coombs test is you take the patient's blood, you centrifuge it, and then you take the serum out of it, and not the blood, RBCs, just the serum, and then you add the serum to the donor blood, and you add the same reagent, the anti-antibody reagent, and then you mix them up and see if it coagulates or agglutinates. If it does, that means it's reacting and it's no good. So anti-donor RBC antibody is present. However, if it doesn't, that means anti-donor RBC antibodies are not present or absent. Okay. So diagnosis, best initial test is CBC with a normal to low MCV, increase in MCHC, and negative Coombs test. A blood smear shows spherocytosis. I'm just going to spherocytosis. 210. Right there. Okay. Most accurate test is eosin 5 millimide flow cytometry, and that is new. We haven't came across that yet. Okay, so for hereditary spherocytosis, this is the test we do. Eosin 5 millimide flow cytometry replaced osmotic fragility test. We used to do that in step 1. And acidified glycerolysis test. Treatment is managed with a splenectomy, stops hemolysis, but spherocytosis will remain, and chronic folic acid replacement assists in RBC production. Patients with hereditary spherocytosis have a characteristically increased MCHC and red cell width, RDW. Key fact here is patients who have splenectomy for any reason are at an increased lifelong risk for sepsis for up to 30 years from encapsulated bacteria, and thus require pneumococcal, meningococcal, and Hemophilus vaccinations before the operation. Okay, AIHA or autoimmune hemolytic anemia. Water break. Drink water. Okay, so autoantibodies against RBC membrane destroy blood cells, causing extravascular hemolysis. Again, that's antibodies are against RBC membrane, destroy blood cells, and it causes extravascular hemolysis. There are two types. There's warm and cold. Warm are IgG associated with LSLE, chronic lymphocytic leukemia, CLL, lymphoma, penicillin, rifampin, phenytoin, and alpha-methyl-dopa. Cold are IgM associated with Mycoplasma pneumoniae, pneumonia, EMB, and Waldenström macroglobulinemia. History and physical examination presents as a hemolytic anemia. Okay, that's helpful. Diagnosis is direct Coombs test. Autoimmune hemolytic anemia is associated with spherocytosis. Spherocytes. Cold agglutinin is the most effective test in cold agglutinin hemolytic anemia. Treatment is, if an autoimmune hemolytic anemia is mild, no treatment is necessary. Warm autoimmune hemolytic anemia is treated with steroids. Recurrent episodes respond to splenectomy. Severe non-responsive hemolysis is controlled with IVIG. Severe cold autoimmune hemolytic anemia is managed by avoiding exposure to cold, keeping patient warm, with or without rituximab, anti-CD20 antibody. Key factor here is both AIHA and hereditary spherocytosis can present with spherocytes and positive osmotic fragility test, but only AIHA will have a positive direct Coombs test. Okay, so in this you don't get it. Okay, we have a negative Coombs test in spherocytes, hereditary spherocytosis, and using 5 millimide flow cytometry is what we do. Okay, so done with autoimmune hemolytic anemia. IgG is warm, IgM is cold. If you have cold, it could be mycoplasma pneumonia, EBV, and Waldenström macroglobulinemia. If it's warm, it's IgG, SLE, CLL, lymphoma, penicillin, rifampin, phenytoin will cause it, and alpha metaldopa. Now on to megaloblastic macrocytic anemia. Impaired DNA synthesis due to vitamin B12 or folate deficiency medications. It leads to delayed maturation of nucleus or precursor cells in bone marrow relative to maturation of cytoplasm. Vitamin B12 deficiency caused by pernicious anemia, malabsorption, for example, Crohn's disease, pancreatic insufficiency, gastrectomy, insufficient intake like veganism, Diphyllobothrium latum or fish tapeworm, or drugs, for example, proton pump inhibitor, antacids, and metformin. Folate deficiency caused by malnutrition, for example, chronic alcohol overuse, malabsorption drugs, for example, methotrexate, trimethorphan, phenytoin. Increased requirement, for example, hemolytic anemia and pregnancy. So all of these will cause megaloblastic. It's basically overuse of all these vitamins and folate and that stuff causing deficiency for newer growing RBCs. Drugs that interfere with DNA synthesis include chemotherapeutic agents, methotrexate, and 6-mercaptopurine. So this is hypersegmentation. The nucleus of this hypersegmented neutrophil has 6 lobes. 6 or more nuclear lobes are required. This is a characteristic finding of megaloblastic anemia because as they grow older and older, more lobes keep on forming. And you start seeing less and less of them in this. Okay. Yeah. Sorry, I said RBCs, I meant neutrophils. History and PE. Megaloblastic anemia presents with fatigue, pallor, glossitis, chillosis, diarrhea, loss of appetite, and headache. Vitamin B12 deficiency causes neurologic symptoms, reversible dementia, and subacute combined degeneration of spinal cord. Vitamin B12 is required in fatty acid pathway and myelin synthesis, involving the spinocerebellar cerebellar tract, lateral corticospinal tract, causing motor and upper motor neuron signs, and dorsocolumn causing sensory and lower motor neuron signs. So that's the one with vibrations, and this one was the spinocerebellar was the well, I'm drawing a blank. It's temperature and pain, right? Temperature and pain. This was the one with the motor neurons going to the muscles, right? And this is the vibration one and proprioception one. Folate deficiency does not cause neurologic symptoms. Folate supplementation and B12 deficiency can correct the anemia, but it worsens the neurologic symptoms. Key fact here is that vitamin B12 deficiency can be caused by infection by a tapeworm, Diphyllobothrium latum. Folate deficiency can occur secondary to chronic phenytoin use, causing malabsorption. Okay, and diagnosis. Here the key fact is also subacute combined degeneration of the spinal cord seen in vitamin B12 deficiency presents as peripheral neuropathy, vibration and proprioception dysfunction, dementia, and spasticity. Diagnosis: best initial test, CBC, decreased hemoglobin, increased MCV, with peripheral blood smear showing RBC, microcytosis, and hypersegmented 6 or more lobes. Neutrophils, see this, okay, vitamin B12 and folate deficiency are identical hematologically and on blood smear. Decreased reticulocyte count, pancytopenia if severe, increase in LDH, increase in indirect bilirubin levels, decrease in vitamin B12 and or folate levels. If vitamin B12 and folate levels are not diagnostic and clinical suspicion persists, the following adjunctive tests can be measured. Vitamin B12 deficiency, there will be increase in methylmalonic acid and increase in homocysteine. And whereas in folate deficiency, there will be normal methylmalonic acid, but however, you'll still have increase in homocysteine. If there was a, let me just go look at. There is a pathway here. Right, so we have B12 making methionine from homocysteine. So if you have this deficient, you'll have a lot more of this, right? And folate over here, if you have deficiency of that, then again you'll have less of cysteine or cystathionine, but more of homocysteine. However, you will still make methionine even in folate deficiency. But with B12 deficiency, you will make more of these, but less of this. Okay, so bone marrow sample revealing giant neutrophils and hypersegmented mature neutrophils. Okay, so you'll see giant neutrophils and hypersegmented mature neutrophils. Like I said, the longer they live, the more mature they get and the more hypersegmented they become. Key facts are, there might be a life lesson in that. Only megaloblastic anemia, for example, due to vitamin B12 or folic acid deficiency, is associated with hypersegmented neutrophils, not non-megaloblastic anemia, for example, due to chronic alcohol overuse or liver disease. Another key fact is that pernicious anemia increases the risk for gastric cancer and is the most common cause of vitamin B12 deficiency in people of European descent. Okay, back to diagnosis. Anti-intrinsic factor and anti-parietal cell antibodies in pernicious anemia. Schilling test, a test that determines if the cause is dietary insufficiency or malabsorption. A Schilling test measures the absorption of cobalamin via ingestion of radiolabeled cobalamin with and without intrinsic factor. This test is rarely performed. Radiolabeled vitamin B12 is found in urine, then dietary vitamin B12 deficiency is present. No radiolabeled vitamin B12 in urine, then pernicious anemia is the cause. Bacterial overgrowth or pancreatic enzyme deficiency. The hypothesis undergoes testing with the addition of intrinsic factor antibiotics or pancreatic enzymes to radiolabeled B12. Okay, now on to porphyria. Disease, affected enzyme, accumulated substrate, and symptoms and treatment. Okay, we'll bring that out again. We'll do that. Okay. So acute intermittent porphyria. The affected enzyme is porphobilinogen deaminase. Right. So the way we did it last time and during step 1 was we go from heme and we go up. And so when you go up, you come across U for uroporphyrogen decarboxylase and then P for porphobilinogen deaminase. And that's how you remember those. So when you go up, the P is for acute intermittent porphyria, porphobilinogen deaminase. Accumulated substrate here, you will have porphobilinogen and ALA, both of these. The symptoms are painful abdomen, port wine colored urine, polynephropathy, neuropathy, psychiatric issues, exacerbated by factors that increase L synthase, drugs like CYP450 inducers, alcohol, and starvation, is treated with hemin and glucose. Porphyria cutanea tarda is the enzyme affected is uroporphyrogen decarboxylase, this one right here, and uroporphyrin causes tea-colored urine. So again, that's going to be your accumulated one. Okay, and what you get is the vampire symptoms like blistering, cutaneous photosensitivity, and hyperpigmentation. Most common porphyria, exacerbated by alcohol consumption. Causes are familial and seen in Hep C. Treated with phlebotomy, sun avoidance, and anti-malarial hydroxychloroquine. Okay, so you go up is you encounter this first, and then that, and that, and then you have ALA and porphobilinogen excess for acute intermittent porphyria. Okay. Treatment here is addressing the underlying cause, intramuscular hydroxycobalamin, if vitamin B12 deficiency due to malabsorption, or vitamin B12 supplementation if due to dietary causes. Oh, okay, so we're still talking about this one. We jumped the queue, but we're done with that. So porphyrias are metabolic disorders caused by dysfunction in the enzymatic activity of heme synthesis, which results in the abnormal accumulation of heme precursors. History and physical examination shows history reveals acute attacks. The physical examination can reveal signs specific to an enzymatic deficiency, such as neurovisceral manifestations, abdominal pain, peripheral neuropathy, and cutaneous photosensitivity or like blistering. Diagnoses are for suspected acute intermittent porphyria, measurement of porphobilinogen PBG in the urine at the time of the attack. Sensitive and specific can be diagnostic. For suspected blistering cutaneous porphyria, measurement of plasma or urine porphyrin can help confirm the diagnosis. Treatment is supportive treatment, pain, nausea, avoidance of trigger factors such as alcohol, smoking, OCPs. Specific treatments we already did over here. So for acute intermittent porphyria, we do treat with hemin and glucose. For porphyria cutanea tarda, we give phlebotomy, sun avoidance, and anti-malarial like hydroxychloroquine. Okay, vampires we treat with phlebotomy, phlebotomy, sun avoidance, anti-malarials, and acute intermittent porphyria is hemin and glucose. Polycythemias, erythrocytosis, and abnormal elevation of hematocrit may be either absolute, like increase in RBC productions, or relative because of decrease in plasma volume and heme concentration. Absolute polycythemia causes are primary polycythemia rubra vera, or secondary caused by hypoxia, or inappropriately increased EPO secretion like EPO producing tumors. History or physical examination. Polycythemias are characterized by increase in hematocrit, increase in blood viscosity, decrease in tissue blood flow and oxygenation, and increase in cardiac work. Absolute erythrocytosis is associated with hypoxia, lung disease, heavy smoking, high altitudes, obstructive sleep apnea, cyanotic congenital heart disease, or poor intrauterine environment. Neoplasia, renal carcinoma, hepatocellular carcinoma, or polycythemia vera. Okay, so absolute erythrocytosis associated with hypoxia, lung disease, heavy smoking, high altitude, OSA, cyanotic congenital heart disease, or poor intrauterine environment. And it's also associated with neoplasia like renal carcinoma, hepatocellular carcinoma, or polycythemia vera. Here they say, okay, so absolute, okay, so they're talking about primary and secondary together. Got it. Polycythemia vera is a myeloproliferative neoplasm that results from colonal proliferation of a pluripotent marrow stem cells caused by a mutation in the JAK2, which regulates marrow production. There is excess proliferation of RBCs, WBCs, and platelets, hyperviscosity, and thrombosis, but RBCs are most significantly affected. RBCs proliferate at an exceedingly high rate despite a low level of EPO. Presentation: hyperviscosity syndrome, easy bleeding, bruising from engorged blood vessels, fatigue, hypertension, thrombosis, arterial and venous, visual disturbance, neurologic deficits, headaches, dizziness, tinnitus, pruritus from a warm bath, congestive heart failure, facial plethora, and splenomegaly. Right. Commonly affects older individuals, increase in 60 years of age. Okay, sorry. In more than 60 years of age, commonly affects older individuals. Okay. Can convert to acute myeloid leukemia in small portion of patients. Okay. I remember this from the mnemonics video that he said that you get pruritus after warm bath because since polycythemia vera increases all the cell line lineages, including mast cells. So now you have excess mast cells which contain histaminics which react with the warm water, the steam or something, and then that's why they release all that and you get pruritus, and warm bath causes itching and all that. Okay, so relative erythrocytosis is associated with hypovolemia and dehydration, diuresis, gastroenteritis, alcohol, and burns. Key fact is hemoglobinuria in a hemolytic transfusion reaction may lead to acute tubular necrosis, okay, and subsequent renal failure. Okay, key fact here, mutation in the JAK2 gene leads to polycythemia vera and accounts for 30 to 50% of the cases of two other myeloproliferative disorders, essential thrombocytopenia and myelofibrosis. Another key fact is myelodysplastic syndromes consist of stem cell disorders due to ineffective hemopoiesis. This leads to increased number of blasts in bone marrow, less than 20% blasts compared to AML, but more than 20% blasts. Okay, so less than 20% blasts. However, compared to AML, it's with more than 20% blasts. Okay. Myelodysplastic syndromes stem from de novo mutations or from exposures, chemotherapy, and radiation. So diagnosis, how do you diagnose it? Best initial test is a CBC showing elevated RBCs, WBCs, platelets, increase in reticulocytes, increase in hemoglobin, increase in hematocrit, and increase in packed cell volume with an arterial blood gas and EPO levels. Decrease in EPO, normal O2, and hematocrit is more than 60%. Key finding here, such as packed cell volume. Such as packed cell volume. Okay. Or PCV. Okay. Most accurate test is the JAK2 mutation present in 95% of patients. That's probably polycythemia vera, they meant to say. Relative erythrocytosis also has an increased hematocrit and splenomegaly, but EPO is normal or increased, and O2 is often low compared to packed cell volume. Okay, so relative erythrocytosis also has increased hematocrit and splenomegaly, but EPO is normal or increased, and O2 is often low compared to packed cell volume. Okay, never mind. Treatment. Okay, so here key fact is PCV has low EPO and normal O2. Relative erythrocytosis has normal or increased EPO and low O2. Treatment here is target is hematocrit less than 45%. So phlebotomy and aspirin provides symptom relief and prevent thrombosis. Hydroxyurea reduces cell counts. Elevated uric acid levels are common due to increased cell turnover. This can lead to gout and kidney stones. Hydroxyurea resistant disease is treated with ruxolitinib or JAK inhibitor. Relative erythrocytosis treatment should address the underlying cause and treat symptoms with phlebotomy. Here, a question. A 49-year-old man comes into the clinic complaining of tiredness over the last several months. His past medical history is significant for hypertension, diabetes mellitus, and alcohol overuse. A CBC reveals a low hemoglobin and an MCV of 115 FL. What is the most likely cause of anemia? So he drinks alcohol, and MCV is this. So alcohol is a cause of megaloblastic anemia. So probably alcohol. Let's see. The patient has megaloblastic anemia caused by either a vitamin B12 or folate deficiency. His history of alcohol dependence strongly suggests folate deficiency. There you go. As that is the most common cause of megaloblastic anemia in patients with a history of acute or chronic alcohol overuse. Okay. Transfusion reactions. Before we do that, am I jumping ahead? Treatment. Okay, so there's a new one. Okay. Variable allergic reaction, anaphylactic reaction, febrile, non-hemolytic reaction, and hemolytic transfusion reaction. Water break. Drink water. Okay. Variable. So mechanism, presentation, treatment, and that's it. Okay. So for allergic reaction, what happens is antibody formation against donor plasma proteins, usually after receiving plasma containing product. This is called the type 1 hypersensitivity reaction. Presentation is prominent urticaria, pruritus, wheezing, and fever. This is, I think, classic for this one. Type 1, wheezing and urticaria. Treatment is stop transfusion immediately, independent of severity of the reaction. Give antihistamines. Give epinephrine is severe reaction. In severe reaction, if mild reaction, then urticaria wanes and there is no evidence of dyspnea, hypertension, or anaphylaxis, can resume transfusion. So if it's mild reaction, urticaria wanes after a while, and there's no evidence of dyspnea or hypertension, then you continue giving it after. So you give antihistaminics, and in severe cases you give epinephrine. Okay, so that was type 1 hypersensitivity reaction to transfusion. Say you have, that was an allergic reaction. Now you can have anaphylactic reaction. This is severe allergic reaction to IgA deficient individuals who must receive blood products without IgA. So presentation here will be dyspnea, bronchospasm, respiratory arrest, hypotension, and shock. So if they have all of these, they're going, because it's a shock, it's given, right? So they have shock, then they're going into anaphylactic shock. Treatment here is stop the transfusion and give epinephrine. Should treat anaphylactic shock as required. Okay. Febrile non-hemolytic reaction. So cytokines formation during storage of blood. Okay, so when it's stored, cytokines are formed, and then host antibodies against the donor HLA antigen and WBCs. Type 2 hypersensitivity reaction. That's what this is. Okay, so you'll have fever, headache, chills, flushing, rigors, and malaise 1 to 6 hours after transfusion. So here flushing is classic for this one. And treatment is should stop the transfusion and give acetaminophen. Leukoreduction of donor blood should be done prior to transfusion. Hemolytic transfusion reaction, acute and within the first hour post transfusion, or delayed, which is within 3 to 10 days post transfusion, due to recipient antibody against donor erythrocytes. Then there is intravascular hemolysis, which is ABO blood group incompatibility, or extravascular hemolysis. Host antibody reaction against donor foreign antigen or donor RBCs. Type 2 hypersensitivity reaction as well. Okay. So I guess this is found in this as well then. Okay, but for this one, the classic one is jaundice. So if you find jaundice, it's probably hemolytic transfusion reaction. Okay. Okay. So fever, hypertension, chills. So hypertension, if you see that, don't just click shock anaphylactic reaction. You need to figure out which one it is out of these two. Here you get bronchospasms, so you have difficulty in breathing as well. Here you get tachypnea, so you hyperventilate. Okay, so burning at IV site, tachycardia, tachypnea, flank pain. Yeah, so this is the classic one for this, flank pain. Renal failure, hemoglobinuria, intravascular hemolysis, jaundice, extravascular during or shortly after the transfusion. The treatment here is should stop the transfusion immediately, vigorous IV fluids, and maintain good urine output. Okay. So for allergic reaction, you'll see urticaria, pruritus, wheezing. Give antihistaminics, stop the transfusion, give antihistaminics, and if it's severe, then epinephrine, and then if it's mild, you can resume transfusion. In anaphylactic shock, it's when IgA deficient individuals are given blood with IgA, and then antigen, sorry, yep. And then presentation is bronchospasm, dyspnea, shock, hypertension. Treatment is epinephrine, stop the transfusion, give epinephrine, and treat as needed. Febrile, which is fever, non-hemolytic reaction, that means no jaundice, no flank pain. How do you treat it? You give acetaminophen, leukoreduction of the donor blood should be done. Hemolytic transfusion reaction, you see tachypnea, tachycardia, flushing, jaundice, and flank pain. Treatment is it should stop transfusion and give IV fluids and maintain good urine output. Blood transfusion reaction. Transfusions are generally safe but may result in adverse reactions. Febrile, non-hemolytic, and allergic reactions are the most common, occurring in 3 to 4% of all transfusions. Okay. So this is febrile, non-hemolytic, and allergic. Okay. So this one and this one. Key fact: pre-medication with acetaminophen and diphenhydramine is sometimes used to prevent minor transfusion reactions. Okay. White blood cell disorders, neutropenia, and okay, an absolute neutrophil count (ANC) less than 1500, where ANC is equal to WBC count times the summation of percent band and percent segmented neutrophils. So neutropenia may be caused by a combination of decreased production, migration away from the vascular space, and increased destruction or utilization. Okay, so it's either not being made, it's being destroyed, or it's being taken away from the vascular space. It may be acquired or intrinsic. The most common cause of neutropenia in adults are infection and drugs. Other common causes include disease that infiltrate the bone marrow, such as leukemias or lymphomas, aplastic anemias, or vitamin B12 and folate deficiencies. Felty syndrome, neutropenia along with splenomegaly and rheumatoid arthritis. So that's a triad. Okay, so neutropenia along with splenomegaly and rheumatoid arthritis. Trying to put that in my brain space. Okay, Felty syndrome. History and physical examination. Patients are at increased risk for infection. Severe infections are typical when it's less than 500 cells per millimeter cube. Acute neutropenia associated with Staphylococcus aureus, Pseudomonas E. coli protease, and Klebsiella or PEC. I think that's what it was. SA, Pseudomonas, and PEC. Chronic and autoimmune neutropenia presents with recurrent sinusitis, stomatitis, gingivitis, and perirectal infections rather than sepsis. Some chronic neutropenias are accompanied by splenectomy, Felty syndrome, Gaucher's disease, or sarcoidosis. Okay. The physician should look for drug or toxin exposure, infection, autoimmunity, or neoplastic disease. Diagnosis: best initial CBC with a peripheral blood smear. Neutropenia is followed up with ANC and thrombocytopenia or anemia with bone marrow aspiration and biopsy. Okay. So if you have neutropenia, these may be the causes: SA, Pseudomonas, PEC, chronic autoimmune neutropenia, presents with recurrent sinusitis, stomatitis, gingivitis, all of these, perirectal infection, sepsis. Chronic neutropenia is accompanied by splenomegaly, Felty, Gaucher's, sarcoidosis. Drugs, toxin exposure, infection, autoimmunity, and neoplastic disease. Key factor is the ANC cells can be obtained by multiplying total WBCs found on CBC by percentage of polymorphonuclear cells and also band cells. Treatment here is infection management. Neutropenic patients cannot mount an effective inflammatory response. It is important to discontinue drugs implicated in neutropenia, which were what were they? Okay, I don't know. Moving on then. Okay, they're giving it here. Okay, so discontinue drugs implicated in neutropenia, neutropenic fever. In context of neutropenia, fever is a medical emergency that calls for immediate treatment with broad-spectrum antibiotics such as cefepime that provides Pseudomonas coverage. Suspected fungal infections are also call for appropriate treatment. Yeah, they didn't give it. Oh well. Hematopoietic stem cell factors such as granulocyte colony stimulating factors or GCSF, filgrastim, can be used to shorten the duration of neutropenia. Rarely, IVIG and allogenic BMT may be used. Bone marrow transplant. Neutropenic fever, defined as single oral temperature of more than 38.3 degrees Celsius or more than 101 degree Fahrenheit in a neutropenic patient. Give me a sec. Okay, so again, neutropenic fever, defined as a single oral temperature of more than 38.3 degrees Celsius or more than 101 degree Fahrenheit, is a neutropenic patient or a temperature of more than 38 degrees Celsius, more than 100 degree Fahrenheit, 100.4 degree Fahrenheit, for more than 1 hour in a neutropenic patient. That is an ANC of less than 500 cells per millimeter cube. History and physical examination. Common in cancer patients undergoing chemotherapy. Neutropenic nadirs 7 to 10 days post chemotherapy. Signs of infection may be minimal or absent. thorough physical examinations, but no rectal examination in light of the bleeding and infection risk. Okay. Diagnosis: CBC with differential serum creatinine, blood urea nitrogen, and transaminases, testing of blood, urine, lesion, sputum, and stool cultures. The physician should also consider testing for viruses, fungi, and mycobacteria. X-ray of the chest for patients with respiratory symptoms, a CT scan to evaluate for abscesses or other occult infections. Okay. So treatment is empiric antibiotic therapy immediately with anti-pseudomonal agent, that is cefepime or piperacillin tazobactam, and vancomycin for methicillin-resistant S. aureus. Coverage in patients with indwelling catheters, pneumonia, or cutaneous abscess. Routine use of colony-stimulating factor is not indicated. If fevers persist after 72 hours, despite antibiotic therapy, the physician should start antifungal treatment, that is amphotericin B or capsofugin. So, empiric antibiotic therapy immediately with anti-pseudomonal agents, and vancomycin for MRSA coverage in patients with indwelling uh, catheters, pneumonia, or cutaneous abscess. And then you do CSF. Oh, routine use of CSF is not indicated, so you don't do that. So why did they include that here? If fever persists over after 72 hours despite antibiotic therapy, then the physician should start antifungal treatment right away. Okay. Lymphopenia versus eosinopenia. Okay, so an absolute lymphocytic count, ALC, is less than 1500 as well. Okay, and this was less than 1500 as well, right? ENC is also less than 1500. Eosinophil is also that. Okay, ALC less than 1500, where ALC cells equal WBC times percent lymphocyte divided by 100. The most common causes of lymphopenia include viral infections such as HIV, congenital disorders like DiGeorge syndrome, severe combined immunodeficiency, sepsis, immunosuppressive medications, glucocorticoids, SLE, chemotherapy, and radiation therapy. So table presents lymphopenia versus eosinophilia. Okay, let's go do that. Lymphopenia definition: absolute lymphocyte count less than 1500, less than 3000 in children. Causes are HIV, congenital disorders like DiGeorge syndrome, SCIDs, sepsis, immunosuppressive medications, glucocorticoids, SLE, chemotherapy, and radiation therapy. Best initial test is CBC with differential. Treatment is asymptomatic. You just monitor. HIV, ART, prophylactic antibiotics for opportunistic infections, immunodeficiency syndromes. You give IG replacement, immunoglobulin replacements. And eosinophilia or penia, absolute eosinophil count of less than 30 cells. Causes are glucocorticoids or Cushing's. Best initial test is CBC with differential. Treatment is asymptomatic. Then just monitor. Note: corticosteroids causes neutrophilia despite causing eosinopenia and lymphopenia. Corticosteroids also impair neutrophil adhesion molecules, limiting migration out of the vasculature to site of inflammation. In contrast, corticosteroids sequester eosinophils in lymph nodes and Okay, so in contrast, corticosteroids sequester eosinophils in lymph nodes and causes apoptosis of lymphocytes. Okay, so history and physical examination. Patients are at increased risk for recurrent infections, especially opportunistic bacterial and fungal infections in HIV and autoimmune disorders. Diagnosis. Best initial test is CBC with peripheral blood smear. Neutropenia is followed up with ANC and thrombocytopenia or anemia with bone marrow aspiration and biopsy. Okay, so CBC, peripheral, neutropenia is followed up with ANC, thrombocytopenia, and anemia or with bone marrow aspiration and biopsy. Treatment is asymptomatic lymphopenia is usually not treated but is monitored. HIV is treated with antiretroviral therapy. Prophylactic antibiotics for opportunistic infections in HIV are the standard of care. In case of immunodeficiency syndromes, immunoglobulin replacement may be considered. Okay, so lymphocyte you do for ALC you do WBC times percent lymphocyte you have and divided by 100. Okay, and for ANC we do ANC equals WBC times the addition of percent band and percent segmented neutrophils. Okay, so eosinophilia. Etiologies of hypereosinophilia. Infectious are helminthic, fungal, protozoal, viral. Autoimmune would be eosinophilic granulomatosis with polyangiitis, previously known as Churg-Strauss syndrome. Also, graft versus host disease. Neoplasm is going to be primary hyper eosinophilic syndromes, several different leukemias and lymphomas. Allergic would be asthma, atopy, allergic bronchopulmonary aspergillosis, acute interstitial nephritis, drug reaction with eosinophilia and systemic symptoms. Drug reaction with eosinophilia and systemic symptoms and drugs. So DRESS. Okay, and miscellaneous is adrenal insufficiency, cholesterol emboli syndrome, acute arterial thrombosis, and radiation exposure. Okay, eosinophilia, an absolute eosinophil count more than 500 millimeter cube. Eosinophilia as a primary disorder is rare. The most common cause in the developed world is allergy, whereas in the developing world it is parasitic infection. So in developed world, it's allergy, whereas in the developing world, it's parasitic infection. And we already looked at the table summarizes the different etiologies of hypereosinophilia. Causes of secondary eosinophilia is NAACP-D. Neoplasm, allergies, asthma, atopy, collagen vascular disease, parasites, and drugs. Common presentations of eosinophilia: allergic bronchopulmonary aspergillosis, allergic reaction in the lungs due to Aspergillus fumigatus, commonly observed in patients with asthma and cystic fibrosis. The chronic inflammation and mucoid impaction can result in lung damage, particularly bronchiectasis and fibrosis. Eosinophilic granulomatous with polyangiitis, a type of vasculitis also known as Churg-Strauss syndrome, which consists of chronic rhinosinusitis, asthma, and prominent peripheral blood eosinophilia. Chronic eosinophilic pneumonia, idiopathic disorder caused by high accumulation of eosinophils in the interstitium of the lungs. History and physical examination will show procurement of travel, medication, and diet history. Inquiry into predisposing conditions, including atopy, asthma, sinus symptoms, cystic fibrosis, peripheral neuropathy, and lymphoma leukemia. Examination directed towards cause. Patients with hypereosinophilic syndrome may present with fever, anemias, and prominent cardiac findings, emboli from mural thrombi, abnormal ECGs, congestive heart failures, and murmurs. Eosinophils are able to infiltrate and affect other organs as well: cutaneous, respiratory, GI, and nervous system. The absolute eosinophil count does not accurately predict organ damage. Diagnosis: CBC with differential. CSF analysis showing eosinophilia is suggestive of a drug reaction or infection with coccidiomycosis or a helminth. Hematuria with eosinophilia is possible sign of schistosomiasis. So you have bloody urine with eosinophil, and you probably have this. Okay. ABPA serum, that's this thing right here we just did. Here we go. Allergic bronchopulmonary aspergillosis. Serum IgE against A. fumigatus or elevated total serum immunoglobulin E concentration. EGPA, that's eosinophilic granulomatous with polyangiitis. Eosinophilia more than 1500 cells, asthma, rhinosinusitis, and evidence on histopathology of eosinophilic infiltration with or without vasculitis. CEP, bronchoalveolar lavage showing eosinophilia with CT chest imaging findings of opacities. Question: a 35-year-old man is airlifted to the emergency department after a motor vehicle accident. He requires multiple transfusions, which stabilize his blood pressure and hemoglobin. The following morning, he is transferred to his hospital room, where he begins to complain of numbness in his fingers. A prolonged QT interval is noted on an ECG. What is the most likely diagnosis? The patient presents with symptoms of hypocalcemia following multiple blood transfusions. Blood products often contain citrate, which bind to serum calcium, leading to hypocalcemia, which can cause prolonged QT intervals. Okay, so treatment of eosinophilia is immediate treatment is new onset cardiac findings, then eosinophilia is more than 100K, and drug reaction with eosinophilia and systemic symptoms must be spotted early and should be treated with steroids and discontinuation of offending agents. Non-emergency treatment: several steroid-sparing agents can be considered, like mepolizumab, a monoclonal antibody directed against interleukin-5, a growth factor needed for the maturation of eosinophils and their activation. Benralizumab, monoclonal anti-interleukin-5 receptor alpha interleukin-5R. Hydroxyurea works by suppressing eosinophilipoiesis. And other treatments are imatinib, features of myeloid disease, interferon alpha, alemtuzumab, anti-CD52 antibodies, and JAK inhibitors, tofacitinib and ruxolitinib. Treatment-specific indications are for aspergillus bronchopulmonary, aspergillus bronchopulmonary something. Allergic bronchopulmonary aspergillosis, right? You give steroids are the mainstay of treatment. Antifungal therapy with itraconazole or voriconazole can be considered in addition to steroids during an acute exacerbation. Omalizumab, humanized monoclonal antibody, should be considered in the setting of poorly controlled asthma. Mepolizumab and benralizumab can be considered in severe asthma and hypereosinophilia. EGPA. Steroids are the mainstay of treatment. During remission, steroid-sparing agents with azathioprine and methotrexate are considered. Mepolizumab and benralizumab can be considered. CEP. What is CEP again? Chronic eosinophilic pneumonia. Steroids are the mainstay of treatment. So mostly you're giving steroids or you're giving mobs. And here you give antifungals in addition to the steroids in acute exacerbation. Okay. Key fact: a characteristic sign of AML subtype M3 or APL is the error rod seen in WBC cytoplasm, although error rods can be seen in other AML subtypes. Okay, so that thing right there. Leukemias. So error rod in AML, the red rod-shaped structure in the cytoplasm of the myoblast is pathognomic. Water break. Drink water. Okay. Leukemias, malignant proliferation of hematopoietic cells characterized by the type of cells involved and their level of differentiation. Acute leukemias, acute myelogenous or lymphocytic leukemias are clonal disorders of early hematopoietic stem cells, so blasts, resulting in unregulated growth and differentiation of WBCs in bone marrow. As the bone marrow becomes replaced by leukemia cells, patients present with features of pancytopenia, anemia, decreased RBCs, infection because of decreased mature WBCs, and hemorrhage because of decreased platelets. ALL or acute lymphocytic leukemia and acute myelogenous leukemia are two subtypes that most commonly affect children and adults respectively. Okay, and most commonly affect, so this one affects children and this one adults. So it used to be ALL and then comes AML, then comes CLL, and then it was CML in the oldest. So this was like young kids, this was young adults, then middle-aged, and then above 60. Right. History and physical examination. Rapid onset and progression. Patients present with signs and symptoms of anemia, pallor, fatigue, thrombocytopenia, pitachi, purpura, bleeding, infection, ineffective and immature WBCs because of that, and disseminated intravascular coagulation, DIC, most commonly seen in acute promyelocytic leukemia, APL. A medullary expansion into the periosteum may lead to bone pain, commonly seen in ALL. Physical examination may show hepatosplenomegaly and swollen bleeding gums from leukemic infiltration and decreased platelets. Leukemic cells also infiltrate the skin and the central nervous system. Diagnosis. Best initial test, CBC with smears showing blast cells. Most accurate test, bone marrow biopsy with flow cytometry to classify leukemia type. Marrow that is infiltrated with blast cells is consistent with leukemia. In AML, the leukemic cells are myeloblasts. In ALL, they're lymphoblasts. These cells can be distinguished by morphology, cytogenetics, and immunophenotyping. WBCs WBC count can be elevated, but the cells are dysfunctional and patients may be neutropenic with a history of frequent infection. If the WBC count is very high, for example, more than 100,000, there is a risk of leukostasis, blasts occluding the microcirculation, leading to pulmonary edema, CNS symptoms, ischemic injury, and DIC. Treatment here is, in general, ALL and AML cases are treated with chemotherapy. Bone marrow transplant is considered in some patients. Oh, okay, right. ALL and AML cases are treated with chemotherapy. Bone marrow transplantation is considered in some patients, especially those with high risk of cytogenetic and those who do not respond appropriately to upfront chemotherapy. Okay. All trans-retinoic acid, or ETRA, combined with arsenic trioxide is highly effective in APL. To prevent tumor lysis syndrome, hyperuricemia, hyperkalemia, hypocalcemia, and renal insufficiency. Hypocalcemia because you have hypophosphatemia and phosphate combines with calcium to form something, and that's why you get low calcium levels. So hypocalcemia. Renal insufficiency, as blasts are destroyed by chemotherapy. Patients should be well hydrated. If WBC counts are increased, they may also be started on allopurinol or raspberry case. Often used in the pediatric population to decrease serum uric acid as renal protection. Raspberry case is contraindicated in G6PD deficiency. Leukostasis syndrome may be treated with hydroxyurea with or without leukophoresis and to decrease WBC count, indicator of poor prognosis. ALL, age less than 1 year or more than 10 years. An increase in WBC count to more than 50,000. Presence of Philadelphia chromosome associated with B-cell cancer. CNS involvement at diagnosis. AML, age more than 60 years. Elevated LDH, poor risk, or complex carrier type. Okay. So here, AML and ALL on peripheral smear. This is AML, large uniform myeloblast. Okay. With round or kidney-shaped nuclei and prominent nucleoli are characteristic. B is ALL. The peripheral blood smear reveals numerous large uniform lymphoblasts, which are large cells with a high nuclear to cytoplasmic ratio. Some lymphoblasts have visible clefts in their nuclei. Okay. CLL, chronic lymphocytic leukemias, a malignant clonal proliferation of mature but functional incompetent lymphocytes that accumulate in the bone marrow, peripheral blood, lymph nodes, spleen, and liver. All CLL cases involve well differentiated B lymphocytes. Primarily affects older adults. Median age is 65 years. The male to female ratio is 2 to 1. History or physical examination. Often asymptomatic patients present with fatigue, malaise, and infection. Common physical findings are lymphadenopathy, hepatomegaly, and splenomegaly. Diagnosis here are best initial test is CBC with differential and smear showing mature lymphocytosis. B cells are more than 500, and characteristic smudge cells, fragile leukemia cells crushed by the slides. Okay, so the smudge cells they occur because of this. Okay. Most accurate test, flow cytometry, shows monoclonal B cells with CD5 and CD23 markers. Question is, a 70-year-old woman with a history of hypertension and lymphoma presents with nausea, vomiting, and fever, and of 2 days duration. She just completed her second cycle of high-dose chemotherapy. She has a temperature of 101 degrees, 0.3 degree Fahrenheit. Her chest x-ray is unchanged, and her WBC count is 900 with 25% neutrophils. After urine and blood cultures have been sent, what is the next step in management? The physician should admit the patient and begin IV antibiotics with anti-pseudomonal beta-lactams, for example, cefepime, piperacillin, teixobactam, meropenem, or imipenem. Febrile neutropenic patients who are on high-dose chemotherapy have a hematologic malignancy or have been neutropenic for more than 14 days should be admitted for empiric IV antibiotics. Okay, again back to diagnosis. Granulocytopenia, anemia, and thrombocytopenia are common as leukemic cells infiltrate bone marrow. Abnormal functions by the leukemic cells lead to hypogammaglobulinemia. Bone marrow biopsy is rarely required for diagnosis but may provide prognostic information. Okay, so don't do that. Treatment is CLL often does not require an treatment due to its indolent nature and natural history. Disease progression should be monitored every 3 to 6 months. Initial preferred agent are ibrutinib or BTK inhibitor, rituximab, anti-CD20 MAB therapy, venetoclax, anti-BCL2 therapy. Treatment, however, is palliative and is often withheld until patients are symptomatic. Recurrent infection, severe lymphadenopathy, or some splenomegaly, anemia, or thrombocytopenia is the poorest. Prognosis, although CLL has a low likelihood of long-term cure, extended disease-free intervals may be achieved with adequate treatment of symptoms. The clinical stage correlates with expected survival. Key fact here is that the presence of smudge cells may indicate CLL. Smudge cells result from cover slip crushing the fragile leukemic cell. CLL right here, and this is your smudge cell. Okay. The numerous small mature lymphocytes with smudge cells, arrow. Fragile malignant lymphocytes are disrupted during blood smear preparation, and they are characteristic. Okay, so smudge cell and CLL. Myeloblasts and lymphoblasts. Variable myeloblasts. They're large. The amount of cytoplasm is more. Nucleoli is conspicuous. Granules are common and fine. Air rods are present in 50% of the cases. Myeloperoxidase is positive. Terminal is deoxynucleotide transferases is TDT, negative. Lymphoblasts, they're smaller. Amount of cytoplasm is less. Nucleoli is inconspicuous. Granules are uncommon and coarse. R rods are absent. Myeloperoxidase is negative, and TDT is positive. CML. Colonal expansion. Okay, so before that, the physician should admit the patient and we did that. Chronic myelogenous leukemia. Colonal expansion of myeloid progenitor cells leading to leukocytosis with excess granulocytes and basophils, and sometimes increased erythrocytes and platelets as well. To truly be CML, the BCR-ABL translocation must be present in more than 95% of patients. This is reflected on conventional cytogenetic analysis by the Philadelphia chromosome 922. CML primarily affects middle-aged patients. Median age is 50. History or physical examination, many patients are asymptomatic at the diagnosis. Typical signs and symptoms are those of anemia. Patients can have splenomegaly with left upper quadrant pain and early satiety. Constitutional symptoms of weight loss, anorexia, fever, and chills may be seen. Okay. Patients with CML in the absence of treatment go through three disease phases: chronic, accelerated, and blast crisis. Chronic. Without treatment, this phase typically lasts 3.5 to 5 years. Infection and bleeding complications are rare. Accelerated. This phase embodies a transition towards blast crisis with an increase in peripheral and bone marrow blast cell count. It should be suspected when the differential shows an abrupt increase in basophil and thrombocytopenia. Platelet count is less than 100,000. Blast crisis. A large percent of untreated CML patients will eventually reach this phase. It resembles acute leukemia. Survival is 3 to 6 months. Diagnosis. Most accurate test, Philadelphia chromosome via polymerase chain reaction or PCR, or fluorescence in situ hybridization or FISH analysis showing the translocation of 922 translocation, although some cases lack the translocation. CBC often shows a very high WBC count, often more than 100,000 at diagnosis, sometimes reaching more than 5,000 millimeter cube. The differential shows granulocytes, predominantly neutrophils in all stages of maturation. Rarely the WBC count will be so elevated as to cause of hyperviscosity syndrome. CML can be confused clinically with a leukemoid reaction, acute inflammatory response to infection with increased neutrophils and a left shift. Leukocyte alkaline phosphatase score is low in CML and other hematologic malignancies, and LAP is high in leukemoid reaction. Treatment here is in chronic tyrosine kinase inhibitor, imatinib. Young patients may be candidates for allogenic stem cell transplantation if a matched sibling donor is available. Blast crisis, same as that for acute leukemia or second generation tyrosine kinase inhibitor, that is dasatinib or nilotinib, plus hematopoietic stem cell transplantation or a clinical trial. Okay, so Hodgkin's. Here, there are a couple of key facts. The presence of smut cell may indicate CLL. Smut cells result from the cover slip crushing the fragile leukemia cells. Key fact here is the likely diagnosis of leukemia is based on age at presentation. ALL less than 13 years, but can present in any age group. AML is 13 to 40 years, but can present in any age group. CML 40 to 60 years, again, and CLL is more than 60 years. Key fact here is lymphocytosis is a common lab finding of CLL. Increase in B cell versus CML, which shows granulocytosis, increase in granulocytes, neutrophils, eosinophils, or basophils. Okay, leukemoid reaction versus CML. You see Dolly bodies in this one. I remember that. CML 19. Okay, so leukocyte count is going to be 50,000 leukemoid reaction, whereas in CML it's going to be more than 1 lakh or 100,000, 10 lakhs, 1 lakh, yeah, 1 lakh. Causes leukemoid reaction, it's caused by severe infection. In leukemoid reaction, LAP score is high. In leukemoid reaction, neutrophil precursor is more mature, metamyelocytes more than myelocytes. Metamyelocytes more than myelocytes. Absolute basophilia is not present, but toxic granulation in neutrophils is present in leukemoid reaction. CML, leukocyte count is often more than 1 lakh or 100,000. Causes are BCR-ABL fusion. LAP score is low. Neutrophil precursor is less mature. absolute basophil is present, and toxic is granulation and neutrophil is not present. I'm just going to quickly go to um, dirty medicines CML and go to this chart that he has made. Okay, so ELL lymphocyte immature happens in age 10 around. It is TDT positive, and cytarabine ARAC is the treatment. And then comes the CML. So ALL, then CML, then AML, then CLL. Okay. And CML, 20% of them turn into AML. CML is neutrophils mature more than it happens in age around 40. Philadelphia chromosome is seen, and imatinib is the treatment. AML, neutrophil is immature because it's acute, and again it happens in middle age around 50. Myeloperoxidase positive aerods are seen in this, and ETRA or vitamin A is the treatment. And CLL lymphocytes mature more around 80 it happens, and there's no treatment because treatment will take longer than their age. The progress of the disease. Okay. And question. A 40-year-old woman sees a physician for a 6-month history of weight loss, fevers, and abdominal discomfort. Her WBC count is 56,000. The physician orders a leukocyte alkaline phosphatase to distinguish between leukemoid reaction and hematologic malignancy. What is the expected result in leukemoid reaction? So over here, it's going to be high if it's leukemoid. Right? And then a 41-year-old man is diagnosed with AML. FISH analysis reveals that he has APL M3 subtype. What is the preferred therapy for this? That's the retinoic acid or vitamin A. Let's see. So the LAP score would be up or increased. Hematologic malignancies, in contrast, have low LAP scores. APL has a favorable prognosis because it is responsive to ETRA therapy. The AML subtype is also associated with an increase in incidence of DIC and a chromosomal translocation involving chromosome 15 and 17. This right here. Okay. So what's the difference between non-Hodgkin and Hodgkin lymphoma? Okay, and this is hairy cell leukemia. Note the hair-like cytoplasmic projections from neoplastic lymphocytes. Villus lymphoma can also have this appearance. Okay. Water break. Drink water. So in Hodgkin's and non-Hodgkin's, let me open this one up. Okay. So okay, so let's do Hodgkin first. Here we had both may have constitutional B sign symptoms, that is low-grade fever, night sweats, and weight loss. Localized singles group of nodes with contagious spread stages, strongest predictor of prognosis, better prognosis in Hodgkin. Characterized by Reed-Sternberg cells, bimodal distribution, that means young adults and in adults of more than 55 years of age. It's associated with Epstein-Barr virus. Here it says single group or localized nodes spreads contagiously and rarely involves extranodal sites. Reed-Sternberg cells, distinct CD1 5 plus and CD30, CD15 plus and CD30 plus B cells. Bimodal young and old and EBV association. Here we have multiple lymph node involvement, extranodal involvement, common non-contagious spread, and worse prognosis. Majority involve B cells, rarely of T cell lineage. Okay, majority B cells, rarely T cells. Can occur in children and adults, so may be associated with autoimmune diseases and viral infections, for example, HIV, Epstein-Barr virus, and HT cell lymphoma or something. I forget. It was a virus, HTLV. Okay. Here we have many peripheral nodes involved, extranodal non-contagious spread, mainly B cell, sometimes T cells. Peak incidence is 65 to 75 years of age, and HIV autoimmune association. Okay. So, hairy cell leukemia, a malignant disorder of well-differentiated B cell lymphocyte. Hairy cell leukemia, HCL, is a rare disease that accounts for 2% of adult leukemia cases, and most commonly affects older males. Median age 50 to 55 years. History PE. History or physical examination typically presents with pancytopenia, bone marrow infiltration, and splenomegaly. Patients complain of weakness, fatigue, petechiae, bruising, infection, especially with atypical myobacteria, such as Mycobacterium avium intercellular, abdominal pain, early CAT, and weight loss. Presentation is similar to that of CLL, except that patients rarely have lymphadenopathy. Okay. Here, key factors. Imatinib is a selective inhibitor of the BCR-ABL tyrosine kinase, the product of the 922 translocation or Philadelphia chromosome. Okay. And again, that's for CML, mature. So it goes ALL, CML, AML, CLL. So LLs are laterally and MLs are medially. That helps. AC, and then, yeah. Okay, so we did that. Diagnosis. For this, it's best initial test is CBC with smear showing pathognomic hairy cells, mononuclear cells with many cytoplasmic projections, or TRAP, that stains with tartrate-resistant acid phosphatase TRAP. Leukopenia can sometimes be seen as well. Most accurate test, flow cytometry, identify the hairy cells. Treatment here is best initial treatment is cladribine. Alternate treatment options, pentostatin, rituximab, and interferon alpha. Medial survival without treatment is 5 years. If left untreated, most patients will develop progressive pancytopenia and splenomegaly, eventually requiring therapy. Lymphomas. Malignant transformation of lymphoid cells residing primarily in lymphoid tissue, especially the lymph nodes. Classically organized in Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphomas NHL represents a diverse group of mature B and T cell neoplasms. Most NHLs, almost 85%, are of B cell origins. NHL is the most common hematopoietic neoplasm and is 5 times more common than Hodgkin's lymphoma. Non-Hodgkin lymphoma types. Type 1 occurs in genetic etiology and comments. So follicular lymphoma, that's the waxing waning type, and it's adults mean age 55 years. Okay, right. So translocation is in 14 and 18. The translocation of heavy chain IG 14 and BCL2 18. So 14 starts with the letter F, so follicular lymphoma. That's how I remember that one. Indolent, coarse, or low grade. Painless, waxing and waning, right? And it happens in adults, age 55 normally. Localized disease, 15% may be cured with radiation therapy. Excuse me. Diffuse large B-cell lymphoma occurs in usually middle-aged and elderly. There's a mutation in BCL2 and BCL, or B-cell lymphoma 2 or B-cell lymphoma 6, right? And mice, MYC. Intermediate grade, most common non-Hodgkin lymphoma in adults. Often presents with single rapidly growing mass, high cure rate with RCHOP therapy, that is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Burkitt's lymphoma. Burkitt's lymphoma is 814. 8 looks like a B, so that's how I remember that one. It happens in children and adolescents. The translocation of C mice, which is 8, and heavy chain immunoglobulin, which is 14. High grade, this is the starry sky appearance, Burkitt. Double T's go with the double S's. Okay. High grade starry sky appearance on lesion biopsy. Jaw lesion in Africa, abdominal lesion in Americas, associated with Epstein-Barr virus, and translocation of 814. Aggressive treatment with chemotherapy. Mental cell leukemia. So here I just imagined a man standing on 2 legs, so the ones are the legs, or a man sitting, and like you just draw a head there, so it looks like a man sitting on a chair. So that's how I remember mental is 1114. Older adult males, translocation is in 11 and 14. So man standing and man sitting. Translocation of cyclin D1, 11, and heavy chain immunoglobulin 14, CD5+. CD5+, rarest form of NHL. Primary CNS lymphoma, adults. In adults is EBV related, associated with HIV and AIDS. And AIDS defining illness, variable presentation, confusion, memory loss, seizures, CNS mass, often single ring enhancing lesion on MRI in immunocompromised patient. So if there's single ring seen in the head, it's usually this one. If there are multiple rings, then it's toxoplasmosis. There's one more translocation, 1118, I think. Let me see. Yep. So marginal zone lymphoma, but I guess it's not as important, but it's associated with chronic. I remember that because I remember the 8 as targets, and then these are the darts, so the darts go into the targets. So 1118. So associated with chronic inflammation, Sjogren syndrome, chronic gastritis, malt lymphoma, may regress with H. pylori eradication. Right. T cell neoplasm, adult T cell neoplasms, adults caused by HTLV, associated with IV drug use, high grade, can progress to ALL, presents with cutaneous lesions caused by HTLV associated with IVDA. Let me just look at this. And HTLV, hold on. There you go. T cell leukemia. Okay. Mycosis fungoides, Sézary syndromes, adults. Mycosis fungoides is a T cell lymphoma of the skin. Cutaneous eczema like lesions and pruritus are common presentations on skin biopsy. See lymphoid cells with cerebriform nuclei. Can progress to Sézary syndromes, T cell leukemia with characteristic Sézary cells seen on blood smears. Okay, so we just finished T cell neoplasms. Now we're on to adapted history and physical examination. The median patient age is more than 50 years, but non-Hodgkin lymphoma may also be found in children who tend to have more aggressive, higher grade disease. Patient presentation varies with disease, but also includes painless peripheral lymphadenopathy, B symptoms, fever, night sweat, weight loss, and masses on examination. Diagnosis are best initial test is excisional lymph node biopsy. A CSF excisional, so you cut it, you don't put in a syringe and take it out. A CSF exam should be done in patients with HIV, neurologic symptoms, and primary CNS lymphoma. Okay. Yes, sir. Here you have the Reed-Steinberg cells. That's what it's called. I have no idea what that is. So that's supposed to be chest x-ray, but it didn't pick up on the thing. I have the book. Let me check it out. Okay, so it's just a picture of chest x-ray with a little haziness on the right sternum, and a little cavitation, I think. Can't really see it in, it's such a small picture. But anyways, Hodgkin lymphoma. Chest x-ray of 27-year-old man presents with several weeks of fever and night sweats. Show bulky bilateral hilar and right paratracheal lymphadenopathy. This is lymph node sampling, shows a mixed inflammatory infiltrate and a classic binucleate Reed-Steinberg cell, the red circle, consistent with Hodgkin lymphoma. Treatment: radiation and or chemotherapy can be used as a therapy. Low-grade indolent non-Hodgkin lymphoma treatment is generally palliative. High-grade aggressive non-Hodgkin lymphoma treatment is aggressive. Okay, chemotherapy. So for aggressive, you go aggressive. With a curative approach, a common regimen is rituximab or cyclophosphamide, doxorubicin, vincristine, and prednisone or R-CHOP. Key fact: the treatment of high-grade non-Hodgkin lymphoma may be complicated by tumor lysis syndrome, in which rapid cell death releases intracellular contents and leads to hyperkalemia, hyperphosphatemia, hyperuricemia, and hypocalcemia. Okay, so that's tumor lysis syndrome there. Hodgkin lymphoma, a predominantly B-cell malignancy associated with Epstein-Barr virus. Hodgkin lymphoma has a bimodal distribution, 30 years of age, primarily the nodular sclerosing type, and is 60 years of age, mainly the lymphocyte depleted type. It has a male predominance in children. Key fact here is on physical examination, lymph nodes suspicious for malignancy are generally described as firm, fixed, non-tender, circumscribed, rubbery, and more than 1 centimeter in diameter. Notice how it doesn't say fluctuant, mobile, mass, right? So if it's cancerous, it's fixed, firm. Benign nodes, usually from infections, are generally described as bilateral, less than 1 centimeter, mobile, and non-tender viral or tender bacterial. History and physical examination. Hodgkin's lymphoma commonly presents above the diaphragm, classically as cervical adenopathy. Infradiaphragmatic involvement suggests disseminated disease. Patients can have systemic B symptoms, pruritus, and hepatosplenomegaly. Epstein virus, 1 to 2 weeks of high fever, alternating with 1 to 2 afebrile weeks. And alcohol-induced pain at nodal sites are rare signs specific for Hodgkin lymphoma. Okay, so after he drinks alcohol or she drinks alcohol, probably he because it's male predominance, at nodal sites are rare signs specific for HL. Okay. Key facts. Chemotherapy and radiation can lead to secondary neoplasms such as AML, NHL, breast cancer, and thyroid cancer. Preventive measures such as mammography are warranted. Diagnosis, best initial steps. Excisional lymph node biopsy shows the classic Reed-Steinberg cells, giant abnormal B cells with bilobar nuclei and huge eosinophilic nuclei, which create an owl-eye appearance. Staging is based on the number of lymph node corps involved, the presence of B symptoms, and whether the disease involves lymph nodes, both sides of the diaphragm, and extranodal sites. For example, bone marrow. Treatment is stage dependent, involving chemotherapy and or radiation in early stage disease. A common chemotherapy regimen is adriamycin, doxorubicin, bleomycin, vinblastine, and dacarbazine, ABVD. Okay, so R-CHOP for that, and this is ABVD. Adriamycin, which is doxorubicin, bleomycin, vinblastine, and dacarbazine. So that's for Hodgkin's. For non-Hodgkin's, it's R-CHOP. So you chop non-Hodgkin's and you abracadabra Hodgkin's. 5-year survival rate are 90% for stage 1 and 2 disease. Nodal disease limited to one side of the diaphragm. 84% of stage 3 and 65% for stage 4. Lymphocyte predominant Hodgkin lymphoma has the best prognosis. Okay, coming on to multiple myeloma. Drink water. Almost out of water, but we're also almost done. So, multiple myeloma serum protein electrophoretic tracing showing M spike, protein spike right here. IgA by A diagnostic for multiple myeloma. Note that M protein spike IgM indicates Waldenström macroglobulinemia. Sorry. Okay, so this is because of IgG, but if you have M spike because of IgM, then it's Waldenström macroglobulinemia. Plasma cell disorder, multiple myeloma. Clonal proliferation of multiple malignant plasma cells with excessive production of monoclonal immunoglobulins, typically ineffective IgA and IgG, and or immunoglobulins fragments, kappa lambda light chains. Multiple myeloma primarily affects older adults, peaking in the 7th decade. Risk factors include radiation exposure and monoclonal gammopathy of undetermined significance, MGUS. History and physical examination. Patient presents with bone pain or with a pathologic fracture. cells infiltrate bone marrow where they activate osteoclasts, creating lytic lesions, weak bones, and hypercalcemia. Patients are prone to infection, immunoglobulin G and immunoglobulin A produced by myeloma cells and are monoclonal, thus making them ineffective, and have elevated monoclonal proteins in serum and or urine. Diagnosis. Best initial test, serum protein electrophoresis showing immunoglobulin G or IgA monoclonal spikes and or serum free light chains. Most accurate test, bone marrow biopsy shows more than 10% monoclonal CD138 plus plasma CD13 and 8 plus plasma cells. CBC with smear may show rouleau formation. This is classic. Whereas urine protein electrophoresis may see Bence-Jones protein, paraprotein, gamma gap, total serum protein, serum albumin is often elevated. M protein alone is insufficient for the diagnosis of multiple myeloma as monoclonal gammopathy of undetermined significance and CLL lymphoma, Waldenström macroglobulinemia, and amyloidosis can also increase M protein. Key fact here is chemotherapy often induces nausea in cancer patients and should be managed with ondansetron, a serotonin 5 HT3 receptor agonist. Okay, mnemonic for clinical features of multiple myeloma. Crab is for C for coolissemia. Okay, or chronic anemia, I think. Renal, no, anemia is over there. So that was that for. Calcemia, right? Hypercalcemia. So, calcemia, renal involvement or recurrent infection, anemia, amyloidosis, bone lytic lesions, and back pain. Their renal insufficiency is because of parenchymal damage on kidney. No, they don't. Okay. And bone lytic lesions, back pain. Key fact here is similar to MGUS is monoclonal expansion of monoclonal plasma cells that is asymptomatic and may eventually lead to multiple myeloma 1 to 2% per year. No CRAB findings are seen in MGUS. Multiple myeloma skeletal survey. And let's see if it's anything important. It's just lytic lesions seen in the skull and bone. That's what they're showing. Yeah. So lytic bony lesions are seen in tibia and fibula and skulls. So it's just like a little cavitation type thing going on there. Key fact, damaging renal tubules can produce adult Fanconi syndrome. Key fact, as is an osteoclastic process, a bone scan which detects osteoblast activity may be negative. Patients should also be evaluated for anemia, hypercalcemia, and renal failures. Bone lesions are also seen with imaging such as skeletal survey treatment. Patients who are candidates can be treated with chemotherapy and autologous bone marrow transplant. Common chemotherapeutic agents are cyclophosphamide, bortezomib, MIB, daratumumab, anti-CD138 antibody, dexamethasone, and lenalidomide. Patients who are not candidates for bone marrow transplantations can be treated with daratumumab, lenalidomide, dexamethasone, cyclophosphamide, and or bortezomib. So all of these. Good luck remembering them. Key fact here, Waldenström macroglobulinemia. Let's go with that first. It is a clonal disorder of B cells that leads to malignant monoclonal gammopathy. Increased levels of IgM results in hyperviscosity syndrome, coagulation abnormalities, cryoglobulinemia, cold agglutinin disease leading to autoimmune hemolytic anemia, and amyloidosis. Tissue is infiltrated by immunoglobulin M and neoplastic plasma cells, a chronic indolent disease of older adults. Key fact here is cryoglobulinemia and cold agglutinins are different disorders caused by IgM antibodies. Cryoglobulinemia is most often seen in hepatitis C virus and has systemic signs such as joint pain and renal involvement. Cold agglutinins may cause finger or toe numbness and hemolytic anemia upon cold exposure and are seen with EBV, mycoplasmal infections, and Waldenström macroglobulinemia. Okie dokie. History and PE. Physical examination presents with nonspecific symptoms like lethargy, weight loss, Raynaud's, from cryoglobulinemia. Organomegaly and organ dysfunction can be present. Neurologic problems ranging from mental status changes to sensory motor, peripheral neuropathy, and blurry vision. Engorged blood vessels can be noted on eye exam are also seen. As with MGUS is a precursor to the disease. For diagnosis is most accurate test, bone marrow biopsy and aspirate. Marrow shows abnormal plasma cells, classically with Dutcher bodies, periodic acid, Schiff, PAS+, IgM deposits around the nucleus. Serum and urine protein electrophoresis and immunofixations are also used. Non-specific findings include increase in erythrocyte sedimentation rate, uric acid, LDH, and alkaline phosphatase. Treatment here is rituximab and chemotherapy for patients with symptomatic disease. Plasmapheresis can remove excess immunoglobulin for patients who present with signs and symptoms of hyperviscosity. Okay, plasmapheresis and this, okay. So for viscosity, we do plasmapheresis to remove excess, okay. Amyloidosis. Extracellular deposition of amyloid protein fibrils resulting from a variety of causes, classically a disease of older adults. History and physical examination. Clinical presentation depends on the type, amount, and tissue distribution of amyloid. And the most common form of systemic amyloidosis, primary, which is AL, or secondary, which is AA, inflammatory has those. The major sites of clinical important amyloid deposition are in the kidney, heart, and liver. Okay, so here we have types of amyloidosis. So AL type is the light one. A plasma cell dichrosis with deposition of monoclonal light chain fragments associated with multiple myeloma and Waldenström macroglobulinemia. AA, deposition of acute phase reactant serum amyloid A associated with chronic inflammatory disease, rheumatoid arthritis, infection, and neoplasms. Dialysis related deposition of beta 2 microglobin, which accumulates in the patient's joints, scapulohumeral joint, and carpal tunnel or long-term dialysis. Heritable deposition of abnormal gene products, for example, trans-13, also known as prealbumin, a heterogeneous group of disorders. Senile systemic deposition of other normal trans-13. So C now is deposition of other normal trans-13. Heritable one is deposition of abnormal gene product, like trans-13, also known as pre-albumin, a heterogeneous group of disorders. Okay. Long-term dialysis would be for beta-2 microglobin deposition. AA is seen in rheumatoid arthritis infection neoplasm, and AL is seen in multiple myeloma and Waldenström microglobinemia. In some disorders, amyloid deposition is limited to one organ. For example, cerebral amyloid angiopathy and Alzheimer's disease. Diagnosis: most accurate test is tissue biopsy with Congo red. We're doing Waldenström. No, we're doing amyloid. It's okay. Okay, tissue biopsy with Congo red. Staining showing apple green birefringence under polarized light. Right. Treatment: primary amyloidosis treated with chemotherapy and or autologous stem cell transplant. Chemotherapy agents are similar to those used in MM. Secondary amyloidosis treated with addressing the underlying condition. Question: a 45-year-old woman presents to the emergency department with fever, chills, nausea, vomiting, and severe flank pain. She has a history of multiple urinary tract infection and was recently hospitalized for pyelonephritis. Urinalysis reveals pyuria and bacteria. Ultrasound performed in the emergency department shows what appears to be perinephric abscess. What is the next most appropriate step in management? And an 80-year-old man is seen in clinic after an incidental findings of elevated IgG on a recent hospital admission for pneumonia. He has no signs of kidney damage, anemia, or bone lesions. The IgG level is high, and a subsequent bone marrow biopsy shows 3% plasma cells. What is the next best step? So the first one, patient with multiple myeloma frequently have renal dysfunction secondary to urinary immunoglobulins, also known as Bence-Jones protein, that have the ability to form casts, leading to cast nephropathy. And for the other one, this patient has MGUS, as seen by the elevated IgG in the absence of other clinical abnormalities or symptoms. No treatment is required, but because MGUS can progress to MM, this patient should be seen regularly for signs of renal failure, anemia, and bone pain. Now, transplant medicine. 3 types of tissue transplantations are increasingly used to treat disease: autologous transplantation from the patient to himself or herself, allogenic transplantation from a donor to a genetically different patient, and synergenic transplantation between identical twins from a donor to a genetically identical patient. With allogenic donation, efforts are made to be ABO negative and HLA match the donor and recipient. Despite matching and immunosuppression, however, transplant may be rejected. There are 3 types of solid organ rejections: hyperacute, acute, and chronic. Graft versus host disease is complications specific to allogenic bone marrow transplant, in which donated T cells attack host tissue, especially the skin, liver, and GI tract. It may be acute, less than 100 days post-transplant, or chronic, more than 100 days afterwards. Minor histocompatibility. Antigens are thought to be responsible for graft versus host disease, which presents with skin changes, cholestatic liver dysfunction, obstructive lung disease, or GI problems. Okay. Patients are treated with high-dose corticosteroids. Typical post-transplant immunosuppression regimen include prednisone, mycophenolate mofetil, FK506 or tacrolimus to suppress immune-mediated rejection, and TMP-SMX, ganciclovir, and fluconazole to prevent subsequent infection in the immunosuppressed host. A variant of graft versus host disease is the graft versus leukemia effect, in which leukemia patients who are treated with the allogenic bone marrow transplant have significantly lower relapse rate of leukemia than those treated with an autologous transplant. This difference is thought to be caused by a recognition of leukemia cells by the donor T cells. Okay, so that's why. Because donor T cells, they start attacking the host leukemic cells. That's why. Okay. Here, hyperacute. Timing after transplant is within minutes, intraoperative sometimes. Pathogenesis, preformed antibodies are attacking it. Tissue findings will be vascular thrombi, tissue ischemia. Prevention is check ABO compatibility, and treatment is cytotoxic agents. In acute, it happens between 5 days and 3 months. Pathogenesis, mixed T cell and B cell mediated response against mismatched HLA class 1 and class 2 antigen. Tissue finding here is lab evidence of tissue destruction, such as increase in gamma glutamate transferases, ALP, LDH, BUN, or creatinine. Prevention, there is no prevention. Treatment is confirmation with sampling of transplanted tissue. Initial treatment with corticosteroid. Additional immunosuppressive therapy can include anti-lymphocyte antibodies, tacrolimus, or myclophenolate mofetil. And chronic, timing is months to years. Its chronic immune reaction causes fibrosis. So here we have vascular thrombi, tissue ischemia. Here we have chronic immune reaction causing fibrosis. There is a gradual loss of organ function. Prevention is this, nothing. And treatment is no treatment, biopsy to rule out treatable acute reaction. So that. So it can be 3 months, so that's why it overlaps with this one. So we do biopsy just to make sure that if it's acute, we can treat it. And chronic, we can't do anything. Okay. Multi-system hematology. Hemophagocytic lymphocytosis, histocytosis, life-threatening state of severe immune system activation due to overactive macrophages and lymphocytes. Water break. I'm out of water. Hemophagocytic lymphohistiocytosis, life-threatening state of severe immune system activation due to overactive macrophage and lymphocytes with phagocytosis of blood cells. This commonly occurs in infants 0 to 18 months, but can be seen in adults of all ages. History and physical examination presents with fever, rash, hepatosplenomegaly, neurologic disturbances, seizures, mental status changes, ataxia, multi-organ dysfunction, cytopenias, coagulopathies, and hemodynamic instability. Okay, diagnosis is clinical findings are as mentioned: increase in inflammatory markers like ferritin, SCD25, and CXCL9. Bone marrow aspirate demonstrating hemophagocytosis. Treatment is actively ill. If they're actively ill, you give dexamethasone and etoposide. Supportive care, blood transfusion for anemia and thrombocytopenia, antibiotics for infection due to pancytopenias, immunosuppressive cytotoxic therapy, for example, dexamethasone and etoposide. Mastocytosis, rare disorder involving excessive release and accumulation of mastocytes in the skin, cutaneous mastocytosis, or other tissues, systemic mastocytosis. History and physical examination. Physical examination demonstrates skin findings: diffuse red-brown cutaneous maculopapular lesion and splenomegaly. Diagnosis: skin or bone marrow biopsy with KIT stain, mast cell specific, with increased mast cell concentration, KIT mutation, serum transcriptase more than 20. Bone marrow biopsy can also show cytopenias due to crowding of the bone marrow by mastocytosis. Treatment is aimed at preventing mast cell degranulation with antihistamines, cromolyn, and anti-leukotriene. Langerhans cell histiocytosis, proliferative disorder of Langerhans cells, uh, characterized by histiocytes, infiltration of tissue, commonly due to BRAF V600E mutation. History and physical examination you'll see here is Langerhans cell histiocytosis. Can present with multisystem involvement, for example, skin, lymph node, lung, and this is the one with the Burbic tennis looking thing, right? I think. Skin, lymph node, liver, lung, and CNS. Skin or oral mucosa can present with eczematous rash, resembles candida infection and or brown purplish pupule. Lung can present with non-productive cough, dyspnea, chest pain, constitutional symptoms, for example, fever and weight loss. Bone can present with localized bone pain due to osteolytic lesions. CNS can manifest as cognitive dysfunction and ataxia. Diabetes insipidus presents with polyuria, nocturia, and polydipsia due to hypothalamic pituitary axis involvement. May also have associated endocrinopathies, hypogonadism, growth of failure, impaired glucose tolerance, diabetes mellitus, and thyroid enlargement. Diagnosis is bone or skin biopsy, pathology demonstrating collection of histiocytes and Langerhans cells, large ovoid mononuclear cells. Treatment depends on the organ involved in the disease. Bone disease can be treated with curettage or radiotherapy. Skin involvement can be treated with topical steroids or methotrexate. Lymph node involvement can be treated with vinblastine chemotherapy. Steroids can also be considered when the lungs are involved along with smoking cessation. And we're done.